exploring more research opportunities. Today, I invite a very special welcome to all of our speakers, Prof. Virginia Ryan Singh, Dr. Ravi Maraj, Dr. Kellyanne Bob, and Dr. Kishan Ramnaresh. We are all truly grateful for your time, for you to share your expertise with us today. Your guidance and experience is what will make these sessions so meaningful and inspiring for everyone here. I'd also like to welcome all staff members who are present, along with our guests, for being here today on a long weekend, the day before Diwali. I'm sure it wasn't easy for you all to be here today, but I thank you. So, research is the foundation on which modern medicine stands. It's what allows us to question, learn, and improve the way that doctors treat their patients. And so the goal of today's seminar is basically to make research approachable and show that anyone, regardless which part or which stage you are in training, can work to be part of meaningful scientific research. But before we begin, just a few quick housekeeping rules. There's a tea and coffee station outside, so if at any point throughout a break in between the speeches you want to go outside and grab a refreshment, please feel free to. And there are also washrooms, male and female, located directly outside on my left. Now, once again, thank you all for being here, taking this step forward for your future, and I hope that we can make this a successful, dynamic, and inspiring session, one that could hopefully spark collaboration between us all, and most importantly, research. So once again, thank you, and we can start today's session. Now I invite Narad Prasad to help us do the introduction for our first session.
Thank you, Sakshi. A pleasant good morning again to everyone. So I'll just be introducing our first speaker, who is a graduate of the University of the West Indies, class of 1994, the pioneering class of Mount Hope. He is a specialist surgeon, having obtained fellowship of the Royal College of Surgeons of England, as well as the fellowship of the American College of Surgeons. He then went on to undertake fellowship training in surgical oncology in Mumbai, India. Dr. Ravi Maraj is currently a consultant surgeon at the Eric Williams Medical Sciences Complex in Trinidad and a senior lecturer within the Faculty of Medical Sciences at the University of the West Indies. He is the current head of department of the Clinical Surgical Sciences at the faculty and the university examiner for the MBBS exam in surgery. He is the author of over 60 peer-reviewed publications to date, as well as the textbook of surgery for medical students. His areas of research include cancers of the hepatopancreatobiliary, gastrointestinal, and mammary system. Let's all please warmly welcome Dr. Maraj with a round of applause.
Thank you very much, and good morning, everyone. So it's good to see all of you all here, and thanks to the Mount Hope Surgical Society for this initiative. Thanks. The Mount Hope Surgical Society. When we met, right, I'm the advisor of the Mount Hope Surgical Society, and every year to think of what are the good topics that we should really, talk about. Last year, I don't know how much of you all were here, but we had a very successful meeting on career day, right? And that was actually quite exciting. And then they came to me and said, well, what again could we speak about? And said, should we have another career day? I said, well, not much change between what we said, for last year and now. So we think, and we always think, well, the area that we should try to push, well, not only for students, but for our staff as well, is research, and we should start that quite early. So I just want to congratulate your team, for putting this together. And we were trying to set a date, and the day before Diwali, wasn't sure, but I think everything will work out good, except also good for some person, or something. Right, but all right, that will work out. I had to run away from home to get away because I had some work going on, I'm not sure everybody think it's cooperative, right? So, and then when we look at the speakers, who should we get? Well, at the end of the day, we can't have a research day without the most prolific publisher in the Caribbean. So we have to thank Prof. Narine, for being here. And to get the time, so that, we actually take time. And my colleagues, Dr. Bob, Dr. Ramnaris, so he's a doctor now, but I knew him since he was going to be sitting down there with me today also. Thanks for taking the time. I want to recognize in the audience the rest of Quadura. I think everybody knows him, lecturer in ENT. Dr. Menzi likes to be nice and quiet, as we call it. Everybody knows that's a lecturer in orthopedics, right? So, in research, what I'm going to be speaking about is how to prepare yourself to do research, what you need to know in order to be part of a team in research. It's hard to do it on your own, you have to be part of a team, but you just can't come and raise your hand and say, I want to be on your team. It's like getting picked for like a cricket team, you have to be good, right? I mean, I'm only West Indies team I'm talking about, in general, a good team, and you have to be good to do that. There's a lot of resistance in doing research. It takes time, It takes time to do research, and there are many other things that you could find to do with your time, I'm sure. Yeah? You could go online, you could do many other things. So why take the time to just do research? That interferes. Remember this word that you all have, that you all love? Work-life balance or something, huh? Yeah. See, in our time it was work. It was work-life balance. And I say, but that's cutting into my time. Why I need to do that? Does it really make a difference in your career? Is it something that I could actually do, as a medical student? That's a big people thing, this kind of researching and publishing a paper. And does research really make a difference in the lives of the patient? That is the most important reason to do the research, right? It's not just because they get the paper, they name. Now, just to get you all a little bit interested, this here is the CV of one of a colleague. And if you look at the CV here, that's everybody's CV. You went to school, went to high school, everybody went to high school, everybody went to good high school, everybody had a little A something, they got you to medical school and they passed medical school, and they went to internship. So how that different to everybody? And I mean, I want to be, fair now. I mean, you all know that it's not in my time where after internship you automatically get a job, right? True? It's competitive now, isn't it? So in other words, we need to find a way to separate yourself, right? So, and I don't want to sound like Sunday morning like in church, right? Because I'm at a quote. So if you look at the book of Matthew, I have to look at this idea, chapter 25, verse 31 to 34. All it's really saying is, what you want to do is to separate the sheep from the goats. And that is what research does. Yeah? So it does help you to get a job, a good job. Now, to be clear, I want to be clear on the not the reason to do the research, but it does help. And why you want to get a job? Why you want to get a job? You want to get a good job? When you get older, you have people to feed. You have your house, you have your car, but it also can give you a good life. It can give you a life that you want to live. I mean, these are things that I wanted to actually do, and it actually helped me to do these things, and you could do it too. You could see things all over. I mean, whatever you want to actually do, right? Start off simple. That's what I would say. Start off good and simple. This is a case report. Yeah. This is the first publication that I did. This was in WIMJ, West Indian Medical Journal. Right? I'm the first author there. And you can see one of the senior authors. Wait. Oh. You see that? So Prof. Narine Singh is here. And so he would have helped me with the first one. And then after that, now years go on and I feel more confident. So now you could become a supervisor. Where's the name, Kishan? Kishan? Was this your first? This wasn't your first. Second. See, he's better than me, right? He's second. So things change, and you must agree. Starting with a case report is nice, easy. It's a simple way to actually start. what does this do? Well, yes, it counts, but you know what it does? It gives you the bug, isn't it? And say, boy, I got publication, boy. You go on Google, you go on PubMed and see your name and you say, nah, I'm feeling good now. I'm making a difference. You want to write, you want to do more and more and more, right? But of course, you have to start off with a simple step, yeah? Remember what the China people say? First step, right? A simple step. And then you can move on and on and on. And once you get about a high level of research, and then you can do things like, cross-sectional studies and all the way down. You can go all the way down. And I don't want to get into this. I know Dr. Bob will have a few things to say, so I don't want to get to cross what other people have to say. But I mean, simple things like a cross-sectional study you can do. And I think I'm working with one of these cross-sectional studies with one of you all, and Kisha and we are also working on these things as well. And this gives you a higher level of data and therefore higher level of the paper that we should publish. But if it is, I want to publish a paper, a certain level of research, and I have my team, and you want to come on my team, with you? You understand? Why I should choose you? Why should you be the chosen one? I don't know you. You have to have something to give, right? Now, we do want research and assistant, because I'll tell you, lecturers, they don't only lecture, they don't only teach, they have plenty of other things. We are actually doctors, we are surgeons, we work. So there's a lot of things happening. So if you can get somebody to at least assist with the groundwork, that will help. But you have to show what it is you have to offer to be part of that team. So I want you all to work on your armamentarium. And that is what this talk is about. Right? And I'll tell you, somebody emailed me about 2 months ago, saying they're interested in research, and in the email he told me what it is he could do. Well, I'm hoping that what he said in the email is true. Right? That's the first thing, but believe you me, we can find out quick, and they answer with other questions. But the thing is, at the end of the day, at least I know that this person, if it is true, at least he could help and not be somebody just there on the paper. So I think that is key, right? So that is what the rest of the talk is, how to arm yourself. So these are the steps in publishing a paper. Many times the first part, the hypothesis, the idea, that comes from your supervisor. We might say things like, as a consultant working in the hospital, I might say, boy, for the past years, I've seen a lot of patients that have cancer in colon. And I find I've seen them plenty. And I've seen at a younger age. And I have a whole set of patients that have that. And you're thinking that's a clinical observation. But you don't have the time, the energy, sometimes, the actual drive, which it is we should do, to look at the data and analyze it. So you have to take that clinical observation, right? And you have a medical student, you have somebody keen and say, let's convert that to a research idea. Yeah? So many times the supervisor will be able to come up with the hypothesis and the idea and say, well, you know what? Oh, I wonder, do we have any data, on that in Trinidad or in the Caribbean and so on and so forth? And you could see for yourself, these are the steps, how it is you can assist. In other words, you interview the work, right? To see if you can become a research assistant. The ones in green are the ones that you will more than likely be able to help with at this point in time in your career. Okay? These are the ones. So let's go for the first step. So your supervisor said, you know what? I want us to look at colorectal cancer in Moldova. Right? So you say, well, okay, well, you know what? We need to do a literature search. So that's the first thing you all need to learn how to do. Now in this talk, I won't be able to expand on every single aspect of research, but I want to give you an idea of what to learn, how to do. So how to do a literature search. And this is simple. You go online, and PubMed is probably the easiest. It's free, most importantly. It's free, so you go onto PubMed, and you type in. You type in right here, colorectal cancer in West Indies and the Caribbean and Trinidad and so on. I have found that if you have a very specific article you want to look at, you could go on single citation and match right across here, and you actually type in the article. the single citation match. So you type in the author's name, you type in the article, you get the article here. And this actually helps a lot. I'm sure everybody knows that. You go on the site and you copy paste. You don't know what copy pasting, single best invention in the world, isn't it? Copy paste, right? And that helps. I have actually known people who there's a citation there and they're going to actually type this whole thing and type every full stop and semicolon, and so they can't do that. They're going to mistakes, so they copy paste it. But as you can see right across here, as you can see here, this will tell you the format that you're going to do the reference in, right? Whether you're going to do it in Vancouver style, Harvard style, and so on. So that's the things that you have to learn. You have to learn how to do a literature search and how to be able to reference it, right? Because we don't have the time to go through all of that. That could be your job. Anything that could help you with this? Who's your best friend now? Yeah. What do you think? That could help? And I agree. I use the AI all the time, and that will help. Any downside, any caution in using ChatGPT for this? Have you all used ChatGPT to get articles? Did you all check the articles to see whether it exists? Does it exist all the time? Do you know that? If it is, you cite an article that doesn't exist, what do you think can happen? It's academic fraud. That equals academic fraud. If you're on my team and you quote an article that doesn't exist, partner, you're out one time. I take it for academic fraud. So be very careful, guys. What does AI do? It hallucinates, right? What I think hallucination is this, right? Because I try to ask ChatGPT what is hallucination, give all kind of answer. You ever meet a friend, a colleague, and you ask them a question, and even if they don't know, just give you an answer? Eh? Just give you some kind of answer, but just give you an answer. Yeah, something that come out of their head. And I take that how the AI cannot say no. It just give you an answer. And I have had ChatGPT give articles that just does not exist. Yeah, so be very careful in doing that, right? I want to be clear, I will be good, because in this generation, use your technology. Technology is there to use, but I want you to use it wisely and use it safely. If it's just one thing that will come out of that, so the day you'll copy paste a ChatGPT and give it to me is the same day you're out of the team, right? I want you to fact check every single thing. But nothing wrong in using it. There's nothing wrong in using it for a lot of different things, for grammar, punctuation, and flow. It gives you a nice flow and the polish of document. Those are the good things about it. Right. So things like to write a proposal, obtain ethical approval, and so on. You need to be a certain level. You need to be a certain provider to be doing those things. But in order to do that, after that, then you get different parties. Collection of data entry. That is hard for us to do. You need to sit down, and that's to actually go down there with the files now, and they're going to check in each file and then to enter his data. Sometimes you want to get a data entry mark, aka a good medical student. And that will definitely help. That's what you said. Let me call a spade a spade, because at the end of the day, a medical student, so you will have at least the knowledge of what to put in and how to decipher information. The clerk will be able to do that, right? They have to have a certain amount of knowledge. I think that this is where it is you really be part of the team. So how are you going to enter this data? So I want you all to arm yourself with the necessary tools. One thing I want you all to learn from now, so everybody uses Excel. Excel is good, but it's not great. Right? There's a certain limit to what Excel could really do. So what you should really start to learn now is SPSS, right? Statistical package, right? And this is so this has been around for years and years and years and years. But there's improvement. What number is now? Is it? I don't know, SPSS has reached, version 30. So plenty of things has been happening, but enter your data on this. Learn it now. Don't go and learn one thing and then, you know what is harder than learning? Unlearning. So when you're accustomed with one thing and then you have to unlearn that and do something, so learn the best for now. And SPSS, many of people say, use that so you'll be accustomed to it. And get accustomed to the data view and the variable view and how to enter. It's not as simple as that. Look at the headings here, because there's different kind of data, right? When you look at this column here, I don't know if you all could. These words are scale and nominal and ordinal and so on. So you have to see what is that thing about, right? And that's important to actually know, and that's different types of data. So yes, you want to enter in SPSS, and yes, maybe ChatGPT can help, but then you have to know what type of data that you're talking about, right? So you have to know, well, okay, if I, let's say, want to look at the time taken to perform an operation, that's a number, right? Hours or minutes and so on. So therefore, that here is numerical. Well, if I want to know how did the patient feel about an operation, how, in terms of the patient experience and those things, those are what they call qualitative data or categorical. And that's important because this here, again, is your SPSS. And these sort of programs will only give you information depending on what you put in. If you put in the wrong thing, you get the wrong information. So when you have to click now on the measure, you'll get a scale, right? And scale is your numerical, and your nominal here is a categorical. So you have to know which one you're going to click, so you get the correct information. Now, yes, maybe the AI can actually help you, but because I ask you about that information, you have to understand it. Because at some point you have to write it up. So you have to understand what you're going to do. Okay? So you have to arm yourself with some knowledge of statistics. This is where it is people have like a barrier. Some people don't. It's like an unnatural thing to the some. For others it's not. Right? So, but if you're going to do high level of research, you have to know some amount of statistics. Yeah? That's fair? Okay. So we can start off with some basic things. Let's see again, I am a consultant in Mount Hope, and I say let's look at the colorectal cancer, the cases in the past year or the past 2 years and so on. Let's just have a look at that. And I tell you as a student, and I go in, when you say look at it, what do you mean? What information that we want? Let's say we look at all of the cases. Well, there are things that you can describe things. So this is called your descriptive analysis. It's things like basic things. What's the difference between the incidence and the prevalence? Yeah, incidence is the number of new cases, and the prevalence is the number of total cases at a given point in time. That's important. But those are basic things, and you don't want to mix it up. Right? Yes, of course, the AI can give you the information, but the thing about the AI, they won't just give you the answer, but they won't give you the understanding of it. So you have to understand the information, And of course, in high school days, you all know how to calculate things like mean and standard deviation. That's just high school stats. That's no big thing. Excel can give you that. You don't need SPSS for all of that. Right? Your phone or your calculator can give you that information. And is that important information? I would say, yeah, absolutely. Let's say that we go back to the past 5 years in Mount Hope, and we look at 100 cases that had cancer of the colon. Right? So your N is 100, isn't it? That is the number of cases. And we found that the mean age is 55, and you have a standard deviation of plus 5 years. Is that important information? Absolutely, right? Because you all know from your reading, because I know you all read plenty, you all know that how in pathology takes about 10 years to go from the normal to a cancer. So therefore you could say, well, you could probably, you read that how in the literature, most people start screening at age 50, But now it takes 10 years to develop cancer, so we should probably start screening at age 45. That's a game changer, isn't it? So something as simple as that could change the lives of patients. And that is what you want to do, right? It's not what you want to do. Yeah, you do research, you want to get a job or thing, but you, at the end of the day, you want to change. That's why you're on the for, to improve the lives of the patients, isn't it? So I have to say that that's a good start. Yeah? So a little bit more, a little bit more. So that's 100 of the patients that you had, and they get it okay. We should start screening at age 45, 10 years prior to the mean age. So you go by the Minister of Health, the government change, and they're interested in doing new things and say, hey, we hear that we could probably start screening at an earlier age. You say, well, but you only look at 100 cases. The population of China is 11 million and more. How could you correlate that to that age? And you say, well, no, I know a little bit more on statistics, and you start to quote the next standard error to mean. So these are little things that I want you all to read about. In other words, how close your mean is to the population mean. And there are ways to calculate that, right? I could get into all of that. Yeah, I could always give you all the PowerPoint afterwards, right? That is not a problem, right? But there are ways to calculate it, and therefore you could get what they call, I think that you have to know is confidence intervals. So by knowing that, you could go to the Minister of Health and say, well, I'm 95% confident that how the mean age of diagnosis in this country is between age 54 and 56. And then we should really start and screen at an earlier age. That's really important information. That's publication. That's a publication. Yeah. And then the Minister might say, well, how to screen them? Everybody should have a colonoscopy. That's expensive. You can't afford that. You want no money. Look at the budget, how things it was. You have no money. You can't afford a colonoscopy. But you could probably order a fit test. That is a stool test for blood, And therefore, you had to quote to him, well, what is the sensitivity of these tests and how specific those tests is, and that 2 by 2 sort of a table. So that's important. So just to remember things like the sensitivity and the specificity. So in terms of the sensitivity, if a sensitive test is negative, if the test is negative, you more or less rule out the disease. Yeah? That is what it is. So that's how to remember it. In a specific test, if that test is positive, you rule in the disease. So these are just little things to remember. So for example, if the fit test is negative, the chances are you don't have colon cancer. Easy peasy, right? Real easy. So that data could save lives. So it tells you how to screen a patient for colon cancer, right? Now we could go more. We could go even more and more. I want to take this at a level. So in many years, this will be a foundation. So I don't want to get into different types of studies, but these are things that you want to actually look at. So you want to know about things like case control studies and cohort studies and so on. So look at those 100 patients that have colon cancer. Look back at the diet, what they eat. See how much of them was eating things like diet like red meats and so on. And of those that have cancer, who had a diet that was high in the red meats. And therefore you could calculate what are the odds of somebody eating the red meat that will get cancer. So not everybody with the red meat is going to get cancer. And we all know there are patients who don't eat red meat who are going to get cancer as well. But what are the odds of increasing that risk? You can also do another study called a cohort, right? So how I remember this is that a cohort have 2 O's, and with a cohort you can calculate what they call the relative risk, 2 R's. Right? That's just, I remember everything. I mean, yeah, I don't remember everything. We are human beings. We can't remember every single thing. Yeah, and therefore they will be able to follow up the patients who eaten the red meat and who are going to get a cancer. Yeah, and that's important information because you know why? That could actually work out things like absolute risk reduction and numbers needed to treat. Meaning that if you have 100, if you tell 100 patients to stop eating red meat, how much of them will not get cancer? That's important. That is the risk. You are trying to make a population healthier. Yeah, those things are important. But know the impact of these things as well, right? This is a statement in breast cancer screening. And what it said that you have to screen, look at the amount of patients, that 2,000 patients have to be screened over 10 years to save one life. That's a lot of mammograms we need to do. So this is what your NNT, the numbers needed to treat. That's why is that important information. Those who make all the rules on screening and so on, they will know in terms of the budget and allocation, how impactful is the screening. And these are things that are important game changers in the field of medicine. All right. So since you're all doing so well, since you're doing so well, let's talk about more on statistics. Things that more concern you all. What do you like to talk about? Exams, right? And exams. How much of you all have done skis already, like in the 40s and 50s in the country? You all would have done, right? You all know what? You all know more. You all would have done, yeah? Year 2, year 3. But you don't know what ski is, right? Yeah, I'm going to ask you about your life, no? Yeah, and how it is we tend to run on our skis, and us as the coordinators and the lecturers. If you think about it, there's plenty of you who write in an exam, eh? There's plenty. So we just can't have one circuit, right? You have one circuit and then, one set of students write and that circuit and wait for that to finish and then the next and the next and then the exam is going on for the whole day. So what we tend to do is to run many circuits at the same time. So, for example, this half in circuit A, the other half in circuit B, and I run at the same time. Yeah. How do you feel about that? That's good. But suppose you in circuit A and you fail. You might say, well, maybe the people in circuit B, that was an easier one. And they might say, I wonder if there was a difference in the outcome in circuit A and circuit B. Yeah? That's important in information. So you go, well, okay, I have an observation. I wonder if there's a difference. So you go, well, I'm assuming that there is no statistical difference between circuit A and circuit B. And that is what something called your null hypothesis. Remember those words? And they want to know whether the null hypothesis is true or not true. So how do we do that? Well, this here, you might be able to see, but these are the results of the candidates, right? Let's see for some reason there. But anyhow, these are the results out of 100. So these here is in circuit A and this is in circuit B. The ones in red, they fail. The ones in blue, they get a distinction and so on and so forth, right? And this is Excel. Real easy. You just import that into SPSS. You go to file and you put import. Real easy. And then what do? You compare the results in circuit A and circuit B. You all can see this here. You can see, just go to analyze, compare the means. Or what sort of statistical analysis would you do here? Anybody knows? You compare two cohorts separately. Because you see, you as a human have to know what knob to press. The SPSS will give you all kind of information, but you have to tell SPSS what to do. Otherwise, they will just give you wrong information. So think about this is probably the most important part. So this is where it is. You see here, is written t-test, right? This is written t-test. So just press student t-test. Okay? And that's what we did. And we see here that how the p-value here is 0.62. So how do you interpret that? 0.62 is more than 0.05, so there was no statistical difference. So in other words, you can have an opinion. That's your opinion, but the facts is clear that there was no statistical difference between circuit A and circuit B. That's important information. Yeah? So you can't come and say, well, I failed because I was in circuit A. You can say so if you want, but that's your business. I give you evidence. Okay? You can ask ChatGPT to do it for you. Not a problem, but understand the data. Yeah. Exams coming up in December for your MBBS. We're not going to have two circuits, I'm going to run 3 at the same time. 3 at the same time. So therefore, I want to know if when I finish the exam, if there's going to be a statistical difference in the mark between A, B, and C. Yeah? So what statistical analysis should I do there? Anybody else? Because you have to know what to press. Anybody can see this word here? And over testing, right? And over testing. Okay? how it is, I remember, if you have two of the cohorts, you do a t-test. You know, God has been good to us. T for two and T for t-test. Not that T stands for two, I'm not saying that, but it's a way to remember. And then they have more than two, and over test. And you see, you have to know what knob to press. If you don't, you're going to give us the wrong answer, right? Now, suppose now, have you ever been in an exam and you finish the exam and say, wait boy, the exam was very hard. But when you find the exam is hard or easy, that depends on how you study, yeah? Right? None of my business. But a better question is, was the exam fair? That's a better, was the exam a fair exam? I think that's how that is the question. Because that is my job, to just to set a fair exam. My job is not to set an easy exam for everybody to pass, or a hard exam for everybody to fail, but a fair exam. So there are many times they will ask the student, when they finish the exam, was that exam fair? And they will give you an answer, yes or no. But what kind of data is that? That is no longer a score, right? That is no longer quantitative data. That is qualitative data. So you see, right in the column here, some people say yes, some people say no, and they compare circuit A and B to see if there's a statistical difference in each of the circuit. Right on top here, this here that looks like a ruler, right? That is quantitative information, and this part here is qualitative. Okay, you have to know which one to press. And what sort of statistical analysis do you do for qualitative? Anybody knows? So you talk about t-test, talk about ANOVA. What is this one? Chi-square. Yeah? So the one that you choose is important, right? So you have to get the correct information. Now, another question, so I'm just giving you all ideas on what you could do. This is major information that you can have here. You know, so some people they come on the exam to say, boy, the exam was fair, no, but they failed. And then the next one say, you know, it wasn't so fair, no, but they passed. In other words, is there correlation? The student really have insight on the exam when they finish. You didn't know whether they did well or they didn't do well. Some students don't, right? In other words, you want to do a correlation. So again, you can put in that information on SPSS, the same thing. And you see this word here? It's called PSS. PSS is called correlation. And SPSS could just your graph with it. Now, of course, ChatGPT can do all of that, but you have to understand what you're doing. Right? You have to understand the information so that when you're writing up now, you can explain it when you're doing the writing. Okay? So this is just a summary. Yeah? I'll give you all the PPT so you have to know which one. So in other words, qualitative data, quantitative data, which one that you will use. Yeah? This is how you arm yourself, and if it is you come to me and you know all of this thing, then you're on the team. For sure, you're on the team. Okay? Alright, I mean, nobody expected to do all this, but I want you all at one time to go higher heights, right? And you become a residence consultant and so on. I want you to be doing things like after-mind curves, and if you want to do a meta-analysis, great. But now take over the team. Yeah? Alright. And then after that, it's time to prepare the paper, how to write the paper. From the right side, I'll tell you. Right? And always have all of the data, how to put it together and so on, right? Now again, yes, you could get a help, but be warned, understand what you're writing. Because we will ask you, well, how you come up with this inference? And you just say, well, ChatGPT said that, no, that's not the answer. Tell me how you got that inference. So write your paper on your own. When you finish writing paper and you want to put it through the AI, for what? For punctuation, spelling, and syntax, and to polish it. I don't have a problem with that, but just check it out. Okay? Choosing a journal, right? When you finish now, you have to choose a journal. Which one do you choose, right? Well, and you can start to scan this QR code if you want, right? This is the password. Choose a journal that is indexed, obviously, on PubMed. If it's not indexed on PubMed, don't worry. Look at the impact factor of the journal. Look at the acceptance rate. If the acceptance rate is too low, chances are they're not going to accept your paper anyway. But if it's too high, you have to be concerned about the quality of the journal. Be very, very careful. And you see this thing here, this is what this QR code will send you a link to. It's important to keep that, right? Ishan, when we ask, the first question that you ask me, what journal is the first thing I tell you? Make sure it's not on Cabell's list, isn't it? Cabell's list is a list of journals that is not recognized here. You know, you're concerned about the ethical standard of the journal. So if you publish on these things, you're affecting your integrity as a researcher. Yeah, you're negatively affected. So look at Cabell's list and make sure that the journal that you choose is not on Cabell's list. And that's why I have it also. All right. So this is a research team. You have the PI, principal investigator. For example, if I want to look at colorectal cancer, I have the idea about colorectal cancer. I put in the proposal, get ethical approval, and so on. So the PI will do that. All of the other consultants who have cases of colorectal cancer, they can be part of the clinicians. The people who look at colorectal cancer, like the pathologists, the gastroenterologists, they are the collaborators. But then you need people like a statistician, research assistants, and the medical writer. This is where you all can help with that. Right? You all can be a major part of the team. Yeah. Now, you need to be smart, right? So you have a high what? IQ, right? Yeah. But you know, when you're a part of a team, this is more important when you're part of a team, eh? You have to be able to talk to people. You can't just be looking down at the computer soon. Right? And this is where this generation of it is lacking. Be able to talk and be able to get information. You have to have a high SQ, social. And I will tell you, see that first paper that I published there, if you would know, it took me from the time to write to the time for publication, 2 years, maybe 2.5 years. The amount of rejection that happens when you publish. You get more level of rejection than acceptance, but that's okay. Well, that is part of it. But you have to be able to, when you get a rejection, you shall be able to pick yourself up, right? And go ahead. In other words, you have to have a high adversity quotient. All this is life, right? All this is part of life. So it's not just, you must have a high IQ. If you have a high IQ, you would be in that. Alright. So let's just take home and messages. Yes, in researching help you to secure a job, to get a job, it gives you a good quality of life, but that's not the reasons to do it. You'll be a valued member of the team. You could be able to find your niche, right? I mean, there are people in this world who could operate well, but they can't write. People who could teach well, but they can't operate. And then there are people who are researchers, but they're not so good at the other parts of it, like being a clinician. But that's why we form a team. Every now and then, maybe every 50 to 100 years, they get somebody like Faulkner and say, will operate well, teach well, and do research well. But that's not a generation. Right? So, for the mortals like us, you have to know where your niche is. Know what it is you're good at, and if you're good at research, you could. That's okay as well. And I could go to a team where you can improve the most important MBFO, improve the lives of your patient on a large scale. Alright? So I'll leave it to you all as that, and we will ask, I guess we can ask questions at the end. I don't know how you want to do it. Right? Okay. Thank you.
Thank you so much, Dr. Raj, for that wonderful talk. I'm sure we all learned a lot from that. Now we're preparing for Prof. Virginia Reinsing's talk, and I'll invite Renee to read his biography.
Following his graduation in 1974, with medals and distinctions in anatomy and surgery, Professor Virginia Reinsing has had a distinguished career that led to fellowships in several international colleges. He was the Reader in Surgery, Personal Chair, and Department Chair at the University of the West Indies. He has served as the President of the Caribbean College of Surgeons and was the Scientific Secretary of the Caribbean Health Research Council for 13 years. He is the recipient of awards from 36 organizations internationally, regionally, and locally for his contributions to medicine, community service, and humanitarian work. At the age of 42, he was one of the youngest recipients of the National Award, the Shakonia Gold, for service to medicine in Trinidad and Tobago. In 2003, he became the first Caribbean surgeon to be granted the Fellowship of the Royal College of Surgeons without examination. In 1991, he was chosen by the Médecins Sans Frontières, Doctors Without Borders, to be one of 5 surgeons worldwide to sit on an international expert panel on colon trauma surgery in Belgium. He was also chosen as the surgeon to the Pope when John Paul II visited Trinidad and Tobago in 1985. He is the first and only UWI graduate to be granted honorary fellowships in the 2 largest surgical groups in the world, the American College of Surgeons and the Association of Surgeons of India. Professor Narayan Singh is one of our university's most published academics. He has authored 10 book chapters on surgery and over 400 peer-reviewed publications in peer-reviewed journals. He has written in every major English-speaking surgical journal, including the prestigious British Journal of Surgery, American Journal of Surgery, Archives of Surgery, the World Journal of Surgery, the Indian Journal of Surgery, the Australian and New Zealand Journal of Surgery, the Journal of Royal College of Surgeons of Edinburgh, the Lancet, and the New England Journal of Medicine. He has delivered presentations on over 200 scientific platforms internationally, regionally, and locally, including papers at the American College of Surgeons, the Mayo Clinic, the Association of Surgeons of Great Britain and Ireland, the Surgical Research Society of the UK, and the Vascular Society of India. He has also published more than 180 abstracts. He has been the recipient of the Vice Chancellor's Award for Excellence in Research and the Carey Science Award for the Most Outstanding Caribbean Researcher. It is my pleasure to introduce Professor Vijay Narayan Singh. So let's put our hands together and welcome him.
Thank you very much. Let me admit before I start, first of all, I must thank the head of the department, I must thank your group, I must welcome Dr. Fondora and Marlon Menzies here. Maybe there are other graduates, I don't know, but it's just wonderful to be here. I was about to say that first let me admit that I am very nervous to present this paper. When I was asked, I tried to find out who I was addressing, whether I was speaking to students, interns, residents, researchers, staff, and it became clear that it could be anybody, which made it really difficult. So this paper, I had to make it very autobiographical, meaning talking about my own work, so that you understand how a researcher, or how this researcher thinks, how a researcher should think. Because while everybody is telling you to write, they don't tell you how to think, but you have to think to write. It's like when you're in high school and your parents tell you to study hard, and nobody's telling you how to study. So you have to think, really, and much of this presentation is how to think, and the last part is on how to write. I must say I'm extremely happy that Dr. Ravi Maharaj covered several. I fear there'll be overlap, but there isn't. He covered areas that I really didn't touch, and thank God I didn't want to touch. So let's go. Now first, is it necessary to write? And I would just skip through this where we covered some of this. You probably know some of the best surgeons, some of the best physicians who never wrote or hardly do write. And it really isn't really absolutely necessary. Having said that, I was presenting how to research at the current medicine and research editorial team of that journal, and as soon as I put up this slide and I said that it is not that some of the best surgeons have them. The chief, the editor of the journal, jumped up from the audience and he said that is not true. In other words, that you cannot be a good surgeon if you do not research and write. And he was a world authority, he's a Cambridge graduate, did the first liver and pancreatic transplants in India. He jumped up and said that's wrong. So if you all think it's wrong, that's okay. But I know that there are many outstanding surgeons who really don't write, and true of physicians too. And then they say surgeons, as Robbie said, who can operate do not write, and those who actually write can't operate. But Francis Bacon, an English philosopher, said that reading maketh a full man, conference a ready man, and writing an exact man. Now that's an important statement, I think, a deep statement, that reading is really very good and very important. And I don't refer only to medical reading, because to be a good writer, you probably should be reading more widely than just medicine. Conference a ready man. But this last line, and writing maketh an exact man, is powerful. And what is this exactitude that writing gives? Writing gives you an exactitude that you cannot get from reading. In other words, when I write a paper, if you ask me sometime later about it, I can tell you what percentage had a misdiagnosis, what percentage had a wound infection, what percentage the mortality was. But you can't tell me that. If I ask you, well, okay, you did 100 appendectomies, how many of them did not have appendicitis? They say, well, I think must be about 10 now. But you don't know. It gives you that exactitude that nothing else gives. I know my error rate was 16% when I was a junior, because I studied it. And anybody asked me, I could actually tell you, in the first 132 cases I did, I had a 16% misdiagnosis rate. Clear. And that's the kind of authority you must have about analyzing your own work. You know how wrong you are, you know what your complication rate is, and so on. Now, also, this exactitude is something that goes to your reading. That's the difference. A writer reads differently from a reader. If you're just reading, and you're reading, and you're reading, a writer reads differently. He looks for what is the age range. He has exact numbers when he's reading a paper, because he reads like a writer. And that's an important, it changes how you read. Your reading is more critical, it is more focused, and you look for specific points when you're reading a paper. You would look carefully at the methodology. If you are a writer, you would read it differently, and your reading becomes very focused. So that is one major benefit from writing. So I think I read a paper, I do write a lot as I say, but I read a paper differently from most, and remember differently too. There are things you would remember that I won't, but there are things I would remember that I consider relevant to what I was looking for. Now, what's the benefit of writing? To me, this is a very important slide. You have to analyze your own data. You have to know your country's data. You have to know your hospital's data. Because you can't speak with authority if somebody asks you, you go to England, you go to America or something, and they ask you something and say, well, I think so and so. This thinking business is not for surgery. Surgery is percentage and figures and means and standard deviations. And you must therefore, when you have that kind of data, be able to compare it to international data and data from elsewhere. Also, when you're analyzing your own work, you'll be focusing on your own local data, on your own local limitations, because you have so many limitations when you work in a setting like this. And when you understand your practice, you now know how you can modify your practice, how you can advise others to modify their practices. But a very important thing, you have a permanent record. Like, I know what my complication rate was in thyroidectomies in 1985. I know what it is in 1995. It is a permanent record of what you were at a certain point in time. And it'll be so for the next 100 years because it's there in writing. As Ravi said, you have to get it right because you can't go back and erase it. And to me, the most important benefit of writing is that it gives you an opportunity to express your view. I don't know how many of you have read Naipaul's book, Letters of Father to Son. But Naipaul, when he was about 20, was at Oxford, and he wrote his father. He had started writing, just as started. And he wrote his father, and he said, but his father was an author here as well. You see, Basad Naipaul was already an author in Trinidad. And he asked his father, what should I write? Who should I address? Should I think about whether the people in England are reading it, or people back home reading it, or intellectuals in Oxford or academics reading it? And his father's answer was very clear. He said, you write what you want to say. Don't think about them out there. And that's a very instructive thing about medical writing. Write what you want to say. If an editor rejects it, which happens all the time, that's okay. But you have to say what you want to say. The editor doesn't like it, that's fine. But you write your story. So that's a very important, and that to me is the most pressing reason why I write. I write because I have something to say. I don't write because I want any promotion or any appointment. I write because of what I want to say. Now, there are certain advantages, of course, is that you communicate with international audiences. They read your work, your writing is read everywhere. Researchers communicate with you directly or via correspondence, which you will see, which I'll have examples of how you can correspond with others internationally. And you engage in controversies. But it is best when you do not need any of these, when you just write because you want to write. I'll tell you what, your writing is read everywhere. I was invited to read a paper in India. And I went and I presented the paper. And at the end, someone from the audience asked me, what was the volume of drainage, because I said you put in a drain, what was the volume of drainage and how long you leave the drain in for? I said that actually we leave the drain in for about 48 hours on average, but I don't remember exactly the kind of volumes. And a guy in the back of the audience jumped up and said, hello, Professor, it was 265 mils with a mean of so on. I said, okay, thank you. You can't lie. You have it in writing. So your writing is read everywhere, and when you don't know something, you just say, I don't know it. That's simple. Now, I know Ravi mentioned this importance of it boosting your CV, and everyone has a basic CV, and you get this edge of a job, of opportunities for postgraduate training, getting scholarships, getting appointments, promotional opportunities, and so on, international recognition. All of that is true, but it is best when none of these apply. I still write. I don't need a promotion. I don't need any of these things here. And I still write perhaps more than most, because that's how it is. So you have to have no good reason except a personal desire to express yourself. And that is the best reason if you have such a. So I wrote before I started university, and I continue to write 10 years after leaving university. Now, this is a very important slide. How to get an idea. You have to think. And thinking doesn't stop. I get ideas sitting down by the beach. I get ideas sitting by poolside, I get ideas on holiday, I get ideas while operating, I get ideas while arguing, I get ideas while reading. It involves thinking. Thinking never stops. And then the other ways you get ideas, knowing the history of your disease, a history of the disease, like you see the history of appendicitis or the history of diverticular disease and so on. Knowing the history and why what we are doing now doesn't seem to answer all the questions. So we have to know the history of current practices. We must and should study challenging and common problems that you encounter. You encounter people with gunshot wounds. Was it so in the 1980s in Trinidad? No. In the 1980s, it was stab wounds. Now it's gunshot wounds. A complete transformation, complete reversal of patterns. But you'll only know that if you go and look at it. So when you study these common problems, you get to understand more about it. And reading gives you great ideas. Sometimes you read something and say, but I could have written that, I should have written that, I could have thought about that. Why didn't I think about that? So reading gives you good ideas. Keeping good records. Now you all, I don't understand how you all will write more. Because we didn't have no phone with camera and thing. And we didn't have all these things about storing data and all that kind of thing. And I hear Ravi Marana talking about again, people to go and sit down and collect data and so on. If I show you handwritten data collected by me personally, stacks of it. Like for example, when the coup occurred. When the coup occurred, I was trapped in hospital for 5 days. I slept on couch, eat whatever sandwich I had in the hospital, but I saw every single patient for 5 days and recorded in detail who was a looter, who was a shooter, who was a police, who was a Muslim, everything, and produced a paper out of it. So you could collect your data yourself. And I like collecting data myself because I don't have faith in the data you collect. You know, I have faith in the data I collect. So you record your data carefully. And you must observe. You must look at your patients. I don't care what the book says. You'll see several things I talk about observation. You can make inroads into the world literature and world understanding of disease by your observation. Because people can't observe better than you. They have the same eyes, you know, like you, and the same hands. You have a head start once you pursue it. And thinking and thinking and thinking. Now, I know this university teaches you about learning facts and so on, and we don't train you to think. But I want to raise ideas with you about thinking. Well, first of all, I gather most of you who are here are people who want to do surgery. So that's a good start. It means you don't think. Because surgeons don't think, they just do. You know, they're plumbers and carpenters, and they cut and they fix and they join, and they don't think, they just learn a trade from the other one, which really, in fact, has much more truth than we think. But anyway, let me see how you think. Do you really believe, honestly believe, I don't want a show of hands, that the earth is round? You really think it makes sense? You really think that this thing is round like that? Why do you think it's round? Because since you're a child, it could be a very round thing to play with. And since they send you some pictures from outer space and they see this round thing, is that a good reason for you to believe that the earth is round? Do you really believe it's round? Simple. But if you believe it's round, then you imagine it's round. Then the guy in Australia, when he jumps, he's jumping so, right? And the guy at the equator is jumping so when he jumps. And the guy in the North Pole jumping so. But the one fellow down here jumping, an interesting jump. I don't know if he'll fall off with that. And then it's more logical to think that there's up there and down there, like it's flat. But if it's wrong, you know, I'm an avid cricket fan. And you often see somebody make some runs or some century and like they're thanking God, they're looking up. But they don't realize that if they're looking up, the direction in which they're looking is diametrically opposite if they're looking 12 hours later, because it's done a spin, half of a spin. And if it is just 6 hours later, they're looking so, and so on. These simple things should occur to us if in fact the earth is round. And if you believe it is round, I'm not saying it's wrong, round. But if you think it is round, and you think it is spinning, let's go and sit down outside. You go and you sit down in the yard there, on a bench, and they tell you this thing is spinning. And it not only is spinning, it is spinning at over 1,000 miles an hour. You sit down there and they tell you this thing that's 1,000 miles an hour. You're mad. Because the diameter of the earth around the equator is about 25,000 miles, so I'm spinning a little over 1,000 miles an hour to cover the distance in 24 hours. And then, you say, nah, that is not true. And then they come and tell you, but it's not only spinning, so it's going around the sun in 365 days, at which it has to be traveling about 64,000 miles an hour. So in addition to spinning at 1,000 miles an hour, you're covering 64,000 miles an hour. You really think that makes sense? That's nonsense. So of course it's not spinning, and of course it's flat. You sit down there, you see the sun come up and it goes so, and it goes so. And then they go under the earth and they come back up and it goes so again. It's more logical. So I'm asking you to start thinking. Now I wrote something here. Where do I have it? Most of you wouldn't recognize this, but it's a 25-cent piece. Now, when I was a student, this would buy me a doubles. So, any one of you who could answer these questions, I will give you this so you can buy a doubles. Now, this is solid, okay? I want you to imagine, now this is an alloy, so I wouldn't go, just to make life simple, let's say this is pure gold. If this is pure gold, it's solid. Now, if this is solid, pure gold, it means that it's made up of atoms, right? Good. So it's made up of atoms. But atoms are made up of a nucleus and electrons moving around the nucleus. Now this gold has an atomic number of 79. So it has 79 protons and has 79 electrons. There's more neutrons than that, but that's another matter. So you have a nucleus and you have electrons. What is the speed at which an electron is moving? No takers? Okay. But I'm telling you, the electrons that are moving here, it's more than 2 million miles an hour inside of this thing. Okay? And spinning at a dizzying speed. And I'm holding it here. I mean, I could feel the shock in my hand because Robbie knows my fingers are very sensitive. I can feel things that other mortals can't. So I can feel the electrons moving here. But the other issue is, if there is a nucleus and there's an electron, what is the distance between the electron and the nucleus? Well, let me make life simple for you. I know you don't know the distance, so I could put this back in my pocket because nobody gained that doubles from me. But if you can enlarge a nucleus to the size of a football, okay, you know where the electron will be? Electron will be 5 to 10 miles away. If you can enlarge the nucleus to be about the size of a football. In other words, the atom is made up of 99.9% of space. So this thing here is actually non-existent. This is pure space, 99.9%, because only made up of atoms and space. And as I'm holding this here, there are about 100 billion neutrinos passing through this every second. So they're actually subatomic particles passing through this as if it doesn't exist. Having said that, I am trying to get to tell you that you should start thinking about ordinary, simple things. You should be thinking about everything you encounter. For example, we do surgery. And when we want to stitch up something tight, we pass the needle and we put the thing on it tight. But the needle we pass is so huge, although we use small needles, that for a bacterium, it's like a 10-lane highway. I'm trying to put things in perspective to get you to understand that you have to think differently. Everybody says that they think. You have to think differently if you want to be a researcher. So now that nobody is going to get my 25 cents, I'll move on. Now, how you get an idea? Careful observation, thinking, creating new techniques, and you see a lot of examples I've used, autobiographical, and you must know the history of procedures for you to change them. Why do they exist as they are, and why and how could I change it? Reading gives you good ideas. Happenstance is important. Things happen. I mentioned about the coup. I didn't know the coup was going to happen. It happened. I didn't know the Marshall Montano disaster, but Marshall Montano disaster happened. I was in hospital at the time. 133 people came in half an hour. And I met and interviewed everybody and documented everything and wrote a paper on that too. That's happenstance. You're just there. So you don't let those things pass. You keep good records. You discuss your stuff with experts, very good. Interact with thinking colleagues. There are not many colleagues who think. Interact with thinking. When you see people who are thinking, you interact with them. And even more rare in surgery, you know. Physicians think a lot. Surgeons do a lot. And you build, as Rabbi Maharaj mentioned, you build teamwork. Look at simple observations. You all, well, I think most of you are not here in clinicals, but for example, podorage. Podorage is in every textbook. But before you get advanced cancers of the breast, to give you the podorage, which is up in that corner there, it'll be more subtle edema of the skin, which you may notice if you ever get swelling of your foot. You'll notice there's a mark with the socks that's more pronounced on one side. Well, it does that at the bra too. But this has been going on, and I just happen to observe that the bra leaves a more marked, a more pronounced mark on the side of cancer, which was never documented in 100 years, because the first bra was worn, the first patent for a bra was in 1914, and this was published in 2012, but 98 years after the bra. So before that, they didn't have bras. The first bra was in 1893, by the way. A lady who took 2 handkerchiefs and tied them with silk and put them on. So it was a handkerchief bra. But the first patent was 1914. So this was never noticed before, and I noticed these and started documenting it, and then wrote this paper about the bra sign being a far earlier feature than podorage in breast cancer, and I wrote a second paper on it as well. So this is about observation. Another observation is this. Even if you look at textbooks of surgery now, you will see that they do this, which is called a deep-loving incision, when a patient has a fractured penis, because the penis is so swollen, you don't know where the fracture is. The penis is swollen like that, and you don't know where the fracture is. And I found that this was gruesome. I mean, to cut that there and skin it right back and deep-love the entire penis just to find a fracture there that is about 1 to 2 centimeters in size and repair it, and then flap back the whole thing down and stitch it back, really made no sense. And I found that on careful examination, you can actually palpate a very soft lump that you can slide your hand over, which was a clot at the site. And I call this the rolling sign. And you can roll, and therefore I can cut here and slide the skin forward, stitch up, repair it like this here, and the skin, the suture is here, the suture line, and the entire swelling will now go down. And we published this in the British Journal of Surgery, British Journal of Surgery as rolling sign, which is the first documentation in the world of a simple sign that will guide how you repair the penis. And at the same time, and the Royal College of Surgeons of Edinburgh published the new technique of how it should be repaired by identifying the rolling sign and using that to guide you. We wrote several more papers on this, so I wouldn't dwell on this, but it shows you the importance of paying careful attention. These are simple things. The bra sign is something everybody should notice, but they never did. A rolling sign is something everybody can notice, but didn't do, and so on. Now look at simple observation. This is a common ulcer you see in the diabetic foot, pressure over metatarsal head. And it generally, if you pay attention to it and just say it's an ulcer, a neuropathic ulcer, notice though it tends to be rounded and it's always just there over the metatarsal head. And a guy comes to me and he's putting potions, getting medicine for his ulcer, but when you look at this ulcer, it is not precisely over the metatarsal head. And it is not round, it is elongated. How could you get trauma going all there? It makes no sense. So he had come to me with the sneakers. So I said, well, I want to see what you wear all the time. So he tells me he wears a slipper at home. I said, well, go home and bring the slipper. And he brought the slipper. And this is what the slipper looked like. The slipper had a piece of bone in it there. That's the bone. And he was sliding his foot over that and lacerating his foot for 2 months before I saw him. And therefore, all I did, I just operated on his slipper and his foot got better. Because if you don't pick up these fine points, and this published in the New England Journal of Medicine, by the way, if you don't pick up these fine, subtle points and be attentive to detail, you can miss important things. Something like this is hardly ever documented. Now, this is another observation. I walked into teaching by accident, and the teacher, a teacher in surgery, was teaching the students, just about 6 students or 8 students in the group, on this patient, and was teaching them about axillary lymphadenopathy, about it being a sign in breast cancer. And I just walked out of the room because that cannot be axillary lymphadenopathy. And the reason is very simple. If you get stretching below the fascia, it stretches the skin rather than folds it. For example, in a pregnancy, the abdomen will stretch and become more shiny and thinner. If you have ascites, it will stretch and become thinner. So therefore, if you have lymph nodes which are deep to the axillary fascia, which is where they are, or deep to the suspensory ligament of the axilla, it should stretch the skin, not cause it to fold. But if you get fat, your skin will fold. You know? So this has to be subcutaneous swelling. And then when we know the embryology of the breast, the breast is from downgrowth of epithelium from the skin. So breast is epithelial downgrowth. It's not from inside. So it can never go deep to the deep fascia. No matter where the breast tissue is, it will always be superficial to the deep fascia, or superficial to the fascia. So this paper is about that. Why this must be, when you see, and we call it the V sign. We call it V sign. That doesn't mean Vijay sign, by the way. It's actually a V. And so when you want Maraca's speech, and you're looking at these ladies, you must look to see if they have a V sign. Because the V sign exists in at least 10% of the female population. You shouldn't get close enough to try to find out if they have a bra sign. That's different. You have to lift the bra to do that. So I wouldn't suggest you try to do that one. Now, so that's observation. The other thing is history. How could you get ideas from history? Now, I think All of you know about McBurney's point, right? So I don't have to go there. But McBurney wrote his paper in 1889. And when McBurney wrote his paper in 1889, in the New York Medical Journal, McBurney could not have known where the base of the appendix was, because X-ray wasn't invented until 1895 by Röntgen. And he did not do postmortem dissections. So in other words, what exists in your textbooks up to today is absolutely false. So anyway, I found as a junior, when I went to do an appendix, and I cut at McBurney's point, I can't find the appendix. And it happened to me so often that I thought that my surgery wasn't particularly good. That's why I can't find it. But I decided to find out. So what we did is, every time they were doing a barium enema, they hardly do barium enema disease, but that was all we had. There was no CT and no endoscopy. So cancers of the colon were diagnosed by barium enema. So lots of barium enemas going on. So I walked around with, just like I walk around with 25 cents in my pocket, I walked around with 3 10 cents in my pocket. 3 10 cents could also buy doubles in those days. And with the 3 10 cents, every time I heard there was a barium enema going on in X-ray department, I'll go down and I'll take out my 3 10 cents, and I'll put 1 10 cents and stick it by the navel. I'll stick 1 10 cents by the anterior superior spine. I'll stick 1 10 cents by where McBurney's point is. And then let's do the post-evacuation film. Because there is dye in the colon. And this is what the post-evac films look like. There is my 10 cents, there's the other 10 cents, there's the one at the ASIS. Look where the appendix is. Right down here. And this arrow is the appendix, this is the appendicocecal junction. And only in 1 in 100 cases did the appendix base lie at McBurney's point. And we published 2 papers on this. So McBurney's really never made his point, or should not have. So that's a knowledge of history. Another thing about knowledge of history, when, you all probably don't know this, but we used to do colostomies up to the 1980s. Colostomies were done for every colonic injury. So once you had a colon, a gunshot or a stab or something, they did a colostomy. But really the origin of that occurred in a paper in 1945 by Ogilvy, because Ogilvy wrote this paper based on war wounds. Now the war wounds of the 1940 to 1945 war was almost pre-antibiotic. Remember antibiotics, 1941 penicillin. So they virtually had no antibiotics, and they out in the fields of certain nasty wounds with injuries to the colon. And what he said was correct. It was correct for that time. They still hadn't refined IV fluids. They hadn't refined blood transfusions. Lots of things changed, but yet this continued as a standard practice up to the 1980s. And when I wrote this paper, like somebody mentioned, I was invited by Medicine Sans Frontières, who are Nobel laureates, to come and address their group about how to repair colon injuries, rather, because they were still doing colostomies for that. And that's why I went to Belgium in 1991 to talk about this, based on this paper. And it's very anti-colostomy paper, because we're in a third world country. We can't go and stick colostomies at everybody who has a colon injury. And then there are unresolved issues. You get ideas by looking at conflicting opinions. You talk to different people and they're doing different things for perforated diverticulitis. And this is a long kata, so I wouldn't go into this story or the Hinchey classification, how obscene it is. But still it exists after 40 years. It's absolutely ridiculous. The Hinchey classification virtually determines what you do based on how much pours out of the leak. So it's like telling me if a duodenal also leak plenty, I should deal with it differently from if it leak a little bit, and so on. And the total illogical position is something that I raised in this paper. So when there are unresolved issues, you have a brain like anybody else and you can address it. And also, we used to do colostomies for obstructed colon. And here you see the obstructed colon is very distended and anastomosis would leak and so on. And we demonstrated that you can, in fact, get the colon to be collapsed by decompressing it and still do a primary anastomosis. So this was unresolved, and now many more people are doing primary repair for obstructed colons. And then reading, I mentioned about why you must read a lot. I was in fact studying abroad in 1982 when Dubois published his paper in French. And although I know a little French, I was able to understand enough of it, but I got somebody to translate the entire paper for me. And he was doing mini laparotomy cholecystectomy. Of course, this was before laparoscopic cholecystectomy was done. And as soon as I came back in 1983, I started doing mini laparotomy cholecystectomy. And here I present this. Here we publish it as an option to laparoscopic cholecystectomy. Remember, only in 4, maybe 5 now of the 14 Caribbean territories do you have laparoscopy freely available in the public service. So there's still room for doing it. And when your equipment breaks down, it's happened from time to time, you may have no option. So wait, something went wrong here. Oh yeah. Now, new ideas. You know, ventral hernias, which are hernias in the midline near your umbilical, your para-umbilical, your supra-umbilical, your epigastric hernias, your fatty hernia of the linea alba, they're all midline hernias. And they're all through the linea alba. You are taught in your anatomy classes, the linea alba is this strong, resilient, white, firm layer. But why is it such a strong, remarkable layer that it's the one that is the place through which you get the hernias? Hernias don't come out on the side of your thing and so on, apart from the inguinal canal. They don't come out through the rectus sheath and so on. But they all come through the midline. And therefore, we designed this operation of bringing the rectus muscles of both sides together and invert the linea alba completely, so it doesn't exist. And this was published in British Journal of Surgery in 1993 about a new way of repairing midline ventral abdominal wall hernias without mesh. And Rabbi Miraz was very involved in this paper, and this is published in the Journal of Medical Hypotheses. There is a journal called Medical Hypotheses. If you can think of something and you can support it by quoting relevant data and relevant material, you can write in the Journal of Medical Hypotheses. And we have hypothesized here that this strong linea alba is really a myth, it's not a reality. And that's what's documented here. And following this, we designed another operation modifying the rectus muscle repair. Now I have to tell this story because probably it'll apply more to postgrads. But I had actually written this paper. I had written this, these are 2 papers. I've written this paper about modifying the rectus repair, the one I described in British Journal of Surgery, modifying it and getting even better results in more complex cases. And when I did that, when we have a research meeting, that's why I go to work with clever people. This clever younger researcher looked at me and said, "Mr. Prof, this is a new technique. Let's do something. Don't publish this paper yet. Let's write a detailed paper on how to do this operation." So, and that paper is the paper on techniques. This paper is modifying it, and this is describing the technique. And after this is published, which took about 4 months, then we publish this and refer this to that, so that we don't have to describe the detailed procedure and then the results. We just refer that to that, and we could spend the whole paper on describing this new procedure. So it's good to work with people who have great ideas, and there's new ideas too. When we're doing a carotid operation for carotid stenosis, we, under local anesthetic, we clamp the carotid. And when the patient does not stroke, we proceed with the operation. If when we clamp it, the patient strokes, then we back, take off the clamp, and decide we're going to put in a shunt. So we'll shunt while working. But we don't like to shunt everybody, it's an additional bit of work to shunt. So that's the standard teaching. And here I said to myself, why can't I obstruct the carotid before surgery? In the clinic, let me obstruct the carotid. So first of all, I tried it on myself. I sat at home and I occluded my right carotid and I stroked. I sat on my bed because I know that if I conk out, I'll be on my bed. And I did. And I did conk out and I got up and I was okay. So now I show it works. So then, what I do, that's a true story. If I occlude my right carotid, I didn't try it on my left, I didn't see the point. I got away once. So, let's see, yes, here. So here I am, I'm occluding his carotid, and I have a nurse standing, and that's his wife there, and I have them looking at him. Because I can't see him if I'm occluding, and I have him raise his left hand, raise your left leg, raise your... And they are going to tell me if his head droop or if anything happened, because I can't see that. And then we designed this test as a pre-operative way. It's a brand new idea in the world literature published in cardiovascular medicine of determining pre-operatively whether you need to shunt the carotid. So really, it's quite safe. You can go home and try it. I suggest you sit on a bed so that if you collapse, you'll be okay. Because once it's less than 4 minutes, you're unconscious for you'll be all right. You know. Now here's another unsolved problem. The fear when you're doing a thyroidectomy is that you could damage the well, everybody talks about the recurrent laryngeal nerve, but that's too much old talk. The real thing that you're more likely to damage is the external branch of the superior laryngeal nerve. And because look where that upper pole is. That upper pole is way up there. The external branch of the superior laryngeal nerve has to come down here to the cricothyroid muscle. So all that length of that nerve is at risk when the thyroid enlarges. In the normal anatomy of the thyroid, the upper pole is right here. So there's very little risk. But as this thyroid enlarges, the risk increases. So it's a big, big problem. And what we did, we just designed a new operation. We say, okay, we're going to start down here, we're going to mobilize the lower lobe, we're going to divide ligament of Berkeley and bring the whole thyroid lobe down. And that's what we did. And we call it a retrograde thyroidectomy, so that we can bring the whole thyroid lobe down, and the upper pole is right there, totally in our control and in the operating field. We can lift the lobe up and down on the upper pole like that. And then after just like I mentioned before, describe the technique first, which is what we did here. And then we did then we did the series. So that's a way of getting 2 papers out of it. And then we got a 3rd paper when I decided to do the sutureless technique, where we don't tie a stitch, we just use the ligature and achieve hemostasis by that. So when you have an idea, you can develop it into multiple publications, each with a different focus, a different emphasis, and getting mileage from it all. And that different focus has a different meaning to different people. Now here's a prospective study we did at San Fernando. When you're collecting data prospectively, it's very important that you decide before you do this study what you're going to look at. And here we decided all the things. We're looking at people who come in with diabetic foot sepsis. We have one column is on the bacteriology, one column is on the antibiotic resistance, one column is on the hospital stay, one column is on the amputation rate, one column is on the cost. So when we finished the study, we actually got 7 papers out of it. These are 3 papers, all out of one study, just because the design of this study was such that all the parameters could be answered by the data we looked for in looking for the cases. And then I mentioned things that happen, like a guy coming with his hand chopped off. Now, I didn't know how to replant a hand, And I hadn't read anything about it, but the guy comes with a hand in his hand. And we have to join it back. So you just know the anatomy and they start to join things and you keep records of it. And we were able to join back his hand, was the first in the Caribbean. And then a few months later, a guy came back with his hand severed at the wrist. And we were able to join that back. He got his power grip and his precision grip. And we were able to publish that because we kept good records both. Similarly, soon after that, a guy cut off his penis. And he came with his penis in a plastic bag. And we were able to join that and publish that in International Journal of Urology. So this thing about even when things happen by accident, you must note it, sit there, keep good records, prospective data, and write your paper there and then. Do not wait for years like people do. Now, you're going to start, and Ravi mentioned this about starting your case report, but I'm going to go through some of these a little bit. There are image sections in journals if you have an interesting X-ray or CT. There are letters to the editor, which we'll go and look at as well, keeping good records. It's very desirable to have a guru to guide you, but it's certainly not necessary. And I would say most of my work was done long before I acquired a guru. But gurus are useful, not essential. When you're writing an abstract, and I know lots of you write abstracts to present at this and to present at that, when you write an abstract, write a paper at the same time. For example, next weekend, one of my juniors is presenting a paper at the Society of Surgeons Trinidad and Tobago, and I told her this week, I want the completed paper. She has to give me the completed paper before she presents the paper. When she gives me the completed paper, I'm going for publication while she's standing up at the podium presenting it. So that's the kind of, if you don't do it then, because if you took the time to write the abstract, it takes just a little more time to write the paper. Now there are images sections in journals, so you can, if you have good images, you can, and this is a very good journal. There are good journals that have, like the New England Journal you saw, has an image section, JAMA has an image section, Lancet has image sections and so on. So you can find image sections to publish your papers. And then there are letters to the editor. Letters to the editor are very nice. They're just one paragraph, two paragraphs. It doesn't require references, or some of them will allow, say, 2 references. But to write a good letter requires a real fair amount of expertise. So you need a guru to write a good letter, somebody at your stage. If you see something in a journal that you don't agree with, take it to your guru, who can then tell you, well, look, what you're thinking isn't right, or something like that, or it's a good idea and let's write it. So writing a letter goes as a publication on your CV as well. Case reports. Well, a case report has the advantage is that it's very easy to write. It just requires a small introduction, the case, a short discussion, and between 2 and 5 references enough for a case report. Very easy to write, very quick, and it is significant if you're starting. Well, I went through a lot of this before. Now, in the art of writing, brevity. Do not write long papers just because you want to look good. The shorter and clearer, the better. In fact, the Nobel Prize that was won by Watson and Crick is a single page, 1 page in the journal Nature in 1953. Very short paper. And when you see words like was, and were, and is, and had, those are bad signs of a badly written paper. You have to, when you're writing, look at ways of avoiding that, and I'll run through that a little bit. Avoid the passive tense. Use a thesaurus or Google to avoid repetition. Use synonyms. And writing only comes with practice. It's like swimming. I can't teach you to swim in the classroom. You've got to jump in the pool and do the movements. And I've written about this too. I've written how to write clearly, and there are books written on it. And these are some examples. Here I mentioned that if you say this paper is relatively simple and it's obviously written for the non-expert, you could say this relatively simple paper is obviously written for the non-expert, and you will eliminate is and. You see? So when you look at the sentence construction, it'll avoid repetition. This paper is an excellent summary of new concepts. This paper excellently summarizes new concepts in carcinogenesis and things like that. Very few references, this is a passive tense, don't use passive tense. Very few references are cited in this paper. This paper cites very few references. Use positive rather than passive, active rather than passive, and avoid just writing style. Now, in writing, the title and abstract are the single most important things. They're not to be just incidental. The title is what draws people to your paper. The abstract is what most people read. Many people read an abstract and don't even bother to read the paper. A well-constructed abstract will sell your paper. Very important to do that. Tenacity, and Ravi mentioned this. Almost no paper is ever accepted fully as submitted. I think Ravi might remember the last paper I mentioned. After 3 rejections, we finally got it in. And right now, I'm sitting on a paper that was been rejected 3 times already. And I think it's so good that I'm going to write again. But you have to keep going at it. But when they make recommended changes, you must do it. I have a 48-hour limit on that. If an editor writes and a reviewer writes and make comments, in 48 hours they're going to get my reply. I'm not leaving it longer than that. They like it back, return right away, and they will accept it. So in conclusion, observation, awareness of history, unresolved issues, reading new ideas, and so on. And writing is not absolutely necessary, but it's good for an excellent clinician to do. It improves your literature memory, your analysis, permanent record of your experience, and it requires good record keeping. Remember that writing leaves a permanent mark. Thank you very much.
Okay, thank you so much, Professor Narayan. Could we give him another round of applause, please? Thank you so much for that engaging discussion as well as the depth of the knowledge which you have shared with us. So now we will have a short intermission of 10 minutes. So you could go and stretch your legs, use your washrooms. We also have a tea station. So you could go grab a tea or a coffee and we'll meet in 10 minutes. So at around 11.
Okay, so we'll now resume with the second part of our Introduction to Research seminar. So we invite you all to get comfortable and listen attentively to our next 2 speakers. We'd now like to introduce our next speaker, Dr. Kellyanne Bob, who will be presenting to us on research for medical students. Dr. Kellyanne Bob is a general surgeon at the St. James Medical Complex. She earned her medical degree and completed her residency in general surgery at the University of the West Indies, St. Augustine campus. Her clinical focus is in breast oncoplastic surgery with a strong commitment to advancing surgical techniques that improve both oncological and aesthetic outcomes. Deeply committed to research, Dr. Bob is passionate about its potential to enhance clinical practice and shape the future of healthcare. Beyond medicine, she is an award-winning photographer who finds inspiration in nature, gardening, and traveling, pursuits that help her stay creative and grounding. Please give a round of applause for Dr. Bob.
to have been considered today to be one of the speakers, especially among such esteemed presenters. Research with medical students is not a small topic, so I've just focused on a few points. You will learn throughout your medical career that you carry a little bit of your mentors as you are exposed to different, in my particular case, surgeons and physicians. And it's not by chance there is some overlap with your presentation. So I will just, certain things that are being repeated, I'll just skip over it a bit. So in terms of the introduction, we see that research has always been a part of medical enterprise and a key component of medical education. It advances medical science in terms of new medications, whether it be in terms of the management of cancers or immune pathologies. And we also have improvement in patient care. For instance, in diagnosing diseases earlier, as Dr. Maharaj had noted, we have the adenoma carcinoma sequence, and it's really understanding of that pathology that we were able to come up with the screening schedule for colon cancer. And well, now we've moved from the age of 50 to the age of 45. And in combination, we are able to add towards reduction of disease and to adding to the information in terms of preventative medicine. Medicine and research on the whole also enhances your portfolio and leads to portfolio development. You'll realize that I didn't say your CV because we've way moved ahead from just expecting to see what school you attended, what were the grades that you achieved. We want to see who you are beyond your medical education and what you have been able to contribute to literature and career progression. CanMed's model is a model that has been described by the Royal College of Physicians and Surgeons in Canada. And it describes the skills physicians need to effectively address healthcare needs of the people they serve. They looked at 7 components, 6 of which you reinforce to describe the medical experts, and I'll focus on 4. The professional is committed to health and well-being of individuals and society through ethical practices, professional-led regulation, and high personal standards and behavior. The scholar demonstrates lifelong commitment to effective learning and creates, disseminates, applies, and translates medical knowledge. The health advocate uses expertise and influence to advance the health and well-being of individual patients, communities, and populations. And all in all, they come together to describe the medical expert. And the medical expert applies medical knowledge, clinical skills, and professional attitudes in the provision of patient-centered care. And these are the components and characteristics that we expect from our graduates from the University of the West Indies. We don't just want you all to be able to regurgitate information, but actually add to the data that is available and improve the overall outcome and management of the patients of Trinidad and Tobago. So all of these components, once we carry all these 6 to 7 characteristics, it will allow us to understand what essentially is evidence-based medicine. And evidence-based medicine is the alignment of research and clinical practice. It has 3 umbrellas: best available evidence, clinical expertise, and patient preferences. Best available evidence is the latest scientific research and findings in patient care and treatment. And clinical expertise is the clinician's accumulated education, experience, and clinical skills. And this accumulation of your experience, clinical skills, and knowledge allows you to go back to best available evidence and lets you, it gives you skills in learning how to really appraise the information that we obtain from evidence-based medicine and decide what is applicable to your society and relevant in your management. In terms of patient preferences, we live in a time where patients are actually coming to you in clinic. They're letting you know that this medication is FDA approved or not. These are the clinical trials they read. Why won't they, why certain informations or management algorithms wasn't given to them or described in terms of their overall management plan. And therefore, we must be also equipped in terms of knowing what is out there, what are the new things, what is being recommended when we are approaching patients in terms of their management. So we have to understand that each patient has unique priorities, concerns and beliefs and expectations, and present our data to them from that background. There is also an ethnocentric bias to evidence-based medicine. Research can be flawed by misinterpreting local phenomena through Western frameworks. And we're only really able to deal with this ethnocentric bias when we add our data. For instance, if we look at the management of breast cancer and risk assessment, if you look at certain risk assessment models, for instance, the Gale model, initially, the patient population that made up the Gale model was more Eurocentric. And we have to ask ourselves, can we therefore just wholesale apply that knowledge to our population that is mainly Afro and Indo-Trinidadians? And the answer would have been no. So the Gale model since then has made certain changes that is a little more holistic. But certain things like that is what we must focus on and understand when we do research in our setting, how we are able to influence these biases. There are many benefits to research. You have critical thinking, scientific communication, literature appraisal, thank you, and fostering of other competencies. Students build critical thinking, problem solving, and data analysis skills which are essential to medical practice. In terms of scientific communication, you gain from research on the understanding of the jargons that are used, and you are able to coherently and build a crucial skill for communication with peers and writing patients' notes. This is a very important point. When you're part of the medical team, and as the intern, which you all are going to be, we expect you all to be able to understand the plan, why it is given, why other things weren't chosen for a patient, and really know what are the important points to document in the notes. 10 years down the road, if a patient decides to sue, no one is going to remember how that day went, what theater was like, what wasn't done or what was done. We are only going to be able to stand on what is written. And your ability to write coherently written patient's notes is also influenced by your ability to understand what is happening around you. In terms of literature appraisal, participation teaches students how to appraise medical literature critically, interpret data, clinical data, and apply research findings. Other things that you're able to foster out of research is the development of skills such as self-directing learning, communication, teamwork, and networking. You will learn that research has, especially in our setting, there are lots of drawbacks. And if you don't have the skills of how to guide yourself through the difficulties and skills of self-directing learning, you're going to be drawn down quite easily and sometimes give up in the very early stages of the research project. Again, in terms of portfolio development, employers, universities, residency programs are all looking for the holistic applicant. And this is evidenced by a portfolio that has a strong background of research. So what questions are important? How do I go about starting a research project? When should I start? Is it okay to only focus on research as part of my course in year 2 or year 3, and then try to get back into it when I'm a house officer or when I'm looking to apply to a residency program? What am I even interested in? What do I want to get out of this? Is it only an oral presentation or poster presentation or publication? Is that my overall goal? Is this case interesting enough to be written up as a case report? What is the current evidence and what type of research can be done? And all of these questions are answered when you have structured programs. So that's why the University of the West Indies introduces research in year 2 and year 3. It gives you a foundation to be able to really ask yourself these questions and even ask it to your mentors or lecturers or consultants that you're exposed to. Discussions with lecturers and consultants as stated, and what is done is also influenced by how much time you actually have to complete a project. So there is a hierarchy of research and different study designs. Different study designs answer different questions. Each study design has its own methodology and strengths and weaknesses, and there is no single study that is perfect. There are 2 umbrellas of study designs: observational studies and interventional studies. Examples of observational studies are case series or reports, case controls, etc. And in terms of interventional studies, is where you compare 2 different arms or 2 different groups. You have an intervention. So, for instance, one of the randomized control trials I'm going to be looking at is the duration of antibiotic use, where one group gets antibiotics for 4 days and another for 10 days. Everything else you hope to keep the same. So there is only one changing variable, and that is the duration of antibiotics. Randomized controlled trials reduce biases. So you have the observer bias. And an observer bias is the ability to reduce your influence on the research. You might assign 2 patients different treatment groups, and if you know exactly this patient has a smaller mass in the rectum versus the next patient, and you want to compare the outcomes of minimally invasive surgery, you might say, okay, well, for the laparoscopic approach, I want to have the patient with a higher lesion, higher in the rectum and smaller in size, versus if you do it for open approach, larger lesions, etc. And those things are biases that can influence the outcome. So having blinding, which is the investigator does not have any knowledge of which arm the patients are being added to, reduces observer bias. And the randomization process on a whole reduces biases in its totality. I'm just going to look at 3 forms of research in terms from the lower tier to the upper tier. And the editorial or expert opinion provides context for research, the interpretation of complex findings, addresses timely policy issues, and guide clinical decisions. Opinions from experienced professionals can offer insights that may be difficult to obtain from data alone, especially in rapidly evolving fields. This is an example of a letter to the editor written by one of our lecturers, Dr. Pran. It was done in August of 2020 when COVID-19 pandemic was at its height. We were still trying to figure out the full extent of the systemic effect of COVID-19 infection. The first 2 paragraphs, he just goes about talking about other viruses that causes thrombosis, both arterial and venous, and then the COVID-19 virus itself. The 3rd paragraph, he goes on to share his experience with COVID-19 infection and viral-induced thrombosis, and then highlights the importance of a high index of suspicion that physicians must carry in the management of this disease process. Quite simple. Just from his experience and his expertise, he's able to sit down and write this editorial, a letter to the editor, that leads to a publication. And this publication is in the Journal of Vascular Surgery, which has a high impact factor, which was mentioned before. And a high impact factor is used to evaluate the relative importance or prestige of a journal within its field. This is important. You don't want to go through the entire, all the work of gathering data, writing up a paper, and then submit it in a paper that is not going to build returns for you. So papers that have low impact factors. A cross-sectional survey is another example of an observational study, and here I highlighted one of the year 2 or year 3 students cross-sectional survey that was done for this year's research day. I don't know if anyone is here who is one of the authors, but I found it interesting. Soft candle use in Trinidad, a cross-sectional survey of pharmacists and community dwellers. The benefit of a cross-sectional study or survey is that it is quick and inexpensive. Data is collected at a single point in time. It is excellent for determining how common a health-related characteristic is within a population over a specific time. You can get a very large sample size and there is no loss to follow-up. However, certain drawbacks is that it is prone to bias. So if we are to look at the objective of this study, So if we are to look at the objective of this study, they wanted to look at the perceived effectiveness of soft candle use in this patient population. 23.5% of these patients actually had boils and abscesses. But there might be some confounding factors that will affect the effectiveness of soft candle use in this patient population. For instance, were any of these people who had abscesses immunocompromised? So were they uncontrolled diabetics on medications such as steroids or chemo medications that would have affected the ability for the investigator to assess the perceived effectiveness of this intervention. In our patient population, they believe that soft candle softens the skin, causes spontaneous discharge of the abscess, and we are dealing with cultural influences also. So another thing that can be done for this study would have been that the investigators looked at a subset of patients that present in the emergency department on call. So if you look at patients who present with abscesses, who require intervention, whether it be an incision and drainage, IV antibiotic administration, and debridement, and ask them if any one of them had a period of use of soft candle use, how long was it, and how long afterwards did it progress, the abscess progress, prompting presentation. But even as this study is presently, it adds to health advocacy, because we are able to say to our patients here, here what? We've done a cross-sectional survey, and this is what we've noticed. Soft candle use doesn't really effectively manage these pathologies, abscesses, etc. And we could also present this data at a conference where pharmacists are present, where we speak to them and give our opinion that, patients who present to you in your pharmacy, who come and they ask for soft candle, we can simply ask them, what do you need it for? And if they say an infective process, speak to them about presenting to a physician or to the emergency department to just reduce the incidence of these patients who present with worsening pathology because of our cultural beliefs. So this, even as it is an example of health advocacy. Now, audits are another example of an observational study. It is a quality improvement study. It systemically reviews patient care against predetermined standards to improve quality and outcomes. It is a cycle of measuring current practice, identifying areas for improvement, implementing changes, and re-auditing to confirm improvement. And this re-auditing of changes is known as a closed-loop audit. And any audit that is performed, ideally you want it to be closed-loop. So this is an example of an audit that we are currently doing at St. James Medical Complex, and it is titled Audit of Breast Cancer in Older Patients. Are they being treated differently? An initial assessment of the TNAB COPS study. And when we were going about looking at the study design, we had to ask ourselves certain questions. We had to define the patient population. We had to look at the study duration, 5 years versus 10 years. The study design, single center versus multi-center. And there's a benefit to both. Single center, the database will be a bit smaller, but you will learn quickly as you go through different research projects that in 2025, ideally no one really wants to look at a single center study. multi-centers are better, especially in our setting where we have multiple hospitals under different RHs where we are able to collect data. Patient characteristics, sex, because not only females present with breast cancer, male patient can also present with breast cancer, and in this database we have male patients also. Medical conditions, a history of polypharmacy, tumor biology, and performance status. We usually use ECOG as our performance status for cancer patients. But when we were gathering this data, something else came up. In patients who are over the age of 70, there's something else that we needed to define, and that was the patient's frailty scores. And from this data thus far, we have begun implementing frailty scores in our patients who are over the age of 65. And this has allowed us to better define and discuss with the patient and family members who are surgical candidates and who aren't, and why a particular treatment plan is going to be presented to them. And one part of our closed loop cycle for this study would be to assess if that has made any change. So audits improve patient care and outcomes. It leads to professional development. The drawback, however, is that it is time and resource intensive. When you have 1,000 notes to go through, when you've identified 1,000 patients, that is not a simple thing to accomplish, and it may only lead to limited impact. So this slide is supposed to have a video that is not playing, so I'll just go through it quite quickly. So a randomized controlled trial is an example of an interventional study, and what I wanted to highlight was the STOP-IT trial. The STOP-IT trial is a landmark trial in surgery. Landmark trials are trials that lead to change in management, essentially. And the STOP-IT trial pioneered limiting the use of excessive antibiotics to patients being presented or managed for intra-abdominal abscesses. It also addressed antibiotic stewardship. It compared two arms. So one arm was an experimental group where patients were given antibiotics for 4 days. So that is this group here. And another arm, which is the control group, where patients were given antibiotics up to 10-day duration. If we look at the number of patients that were added in both arms, we have 256 in the experimental group, 260 in the control group. But there is something that must be worked out for a randomized control trial, and that is the power of the study. The power allows us to appropriately detect differences. And for any randomized control trial, when we look at a power of 80%. In this trial, a power of 80% needed to have 505 patients in both arms. So we are saying this is supposed to have 505 and this one's supposed to have 505 patients. This study concluded that there was no difference in their primary outcomes. The primary outcomes were surgical site infections, recurrence of intra-abdominal abscess, and death at 30 days. So in both arms, it was, I think, 22.1 and 23% of the patient population did not have, patient population presented with either surgical site infection or recurrence of intra-abdominal abscess, and that was not statistically significant. Dr. Maraj already spoke about that. Statistical significance has a p-value of less than 0.05%, less than 0.05. So what they concluded is that patients who has source management, whatever was the cause of the abscess in the abdomen, could have safely been managed with antibiotics for 4 days alone. You didn't need to go beyond that. But when it is you look at the data and realize that it's underpowered, we understand that the data likely has an increased likelihood of a type 2 error. And a type 2 error or false negative occurs when a study fails to detect a relative effect or difference. And this is not enough for me to be able to say to my patients, you know, here what, you still have a temperature spike, your white blood cell is still 60, but the STOP-IT trial has said to me from its evidence that I can give you 4 days of antibiotics and that's it. Because I understand how to critically appraise a paper, which is what each and every one of you will have to do with the data that is available, because there is a lot of data. But not everything that we read or that looks shiny is something that we can trust. So critical appraisal is an essential skill that you're going to have to be able to write your papers and also implement management in your patients. But there are particular obstacles to research, and we have to ask ourselves, how can we get beyond it? There are infrastructure gaps. There is the lack of electronic medical records. There are very few hospitals in Trinidad and Tobago that have an electronic database. I am blessed to work at a hospital where we have an electronic system, but it's still not used at its maximum capacity. We don't have a coding system where I could just simply search all patients with a particular pathology and get a database right there. So having to go and present yourself to medical records with a list of files that you need to get is something that is going to affect the timeliness of your data collection. There might also be missing data and patients may be lost to follow-up. In our setting, some patients start management at one hospital and continues their follow-up at another. In terms of the team, we usually would have an experienced mentor, and the ethics committee is available through any of the hospitals under the RHA or through the University of the West Indies. But the research assistant and statistician is someone that is not always available. As stated before, we hope that some of you all will present yourself and ask us, if there is a project that you all could assist us with during your vacation or anytime. We will be glad to have you, because the more hands we have is the shorter the time to collect data and tabulate data. A statistician, we usually look at getting a statistician on board at the time of analysis of data. But you will learn that from the time you are defining your methodology, if you could get someone with that background there at that point, it will save you time of having to go back and collect more data when you realize the data that you have cannot give you the outcome that you set out to achieve. Funding and resources is another constraint. We have limited financial support, and when you get to the point of publication, you will quickly learn that most of these high-impact journals are not free to publish with. Some are $1,000, some are £3,500. And usually the members come together, the members of the team usually come together to fit that bill. But it's not a simple thing. All right? So those are some of the things to keep in mind. In terms of the project timeline, where do we get stuck? We usually get stuck right here at publication submission. And this is because of some of the difficulties that we come against. Time constraints. You might say to yourself, I can only do research in year 2 and year 3, I need to study, I need to finish so I can become a doctor. And when I finish medical school, I would then focus on research. But you will learn you're going to be a house officer, you're going to be up and down, you're going to be post-school, you're going to be tired. We have to learn how to balance competing priorities. There will never be enough time. And research is not optional. Research is necessary. People are going to look for that in your CV, and again, as Dr. Maraj and Professor Narayan Singh said, that should not be your endpoint. Your endpoint shouldn't be to just have a CV to get a job or find yourself in a residency program. It should be for you to be able to add, to be an active member of the medical field and add to the data that is out there. It requires significant expansion and detail required for a manuscript. And one of the pearls given by Professor Narayan Singh, when you finish writing up your abstract, start working on your publication. When it is you already have that momentum, all of the information is actively in your mind, it is going to be an easier process to expand on the detail that is required for publication. I had a little slide also on AI and medical research. There was a systemic review that noted that ChatGPT improved writing and was useful in healthcare research and benefited healthcare practice and healthcare education. However, it also highlighted 4 issues. There's accuracy issues and potential for algorithmic bias. And that is because ChatGPT is only able to come up with certain methodologies or objectives by what is being fed. It's highly influenced by what is being fed, right? So if it only has a database from English-speaking publications, it can only give you that, right? There is a lack of originality and critical thinking and over-reliance. When it is you depend on AI, especially at this early stage of your research journey, all of the skills that is required for you to really come up with new and novel things and to add in a beneficial way to the data that is out there is dependent on your foundation. And if it is you going to cripple yourself by just feeding AI with certain information and allowing it to generate ideas for you, it's not going to be beneficial in the long run. There are ethical challenges like plagiarism and copyright, and privacy and security is an issue. If you use AI, ChatGPT, to generate all of your statistical analysis, for you to be able to do that, you have to feed it your entire database. And if something happens, how are you going to say when a patient's information given, we usually code and we might assign a number. But if your hospital is identified as one of the hospitals where your data is leaked, that's not going to look good and it's not ethical. There is an overall erosion of scientific integrity to the point that journals are updating policies to prevent the use of AI-generated text, images, or graphs, as AI cannot be an author, and such use may be considered scientific misconduct. Most of these journals, when you come to the point of submission, is going to ask you to click that little box that says your data or your manuscript has not been done up with the use of AI. And if you cannot click that box at that time, with all the work you've done, you've wasted time. Or if you click it and they learn that you lied, you lose all credibility with that journal. You would no longer be able to submit in the future. So those are some of the things for you all to consider. So in conclusion, find a project relevant to medical issues that you are interested in and look for opportunities in ongoing projects. Consider if you have access to necessary resources and if collaboration is possible. There is nothing wrong with doing a case report. You require less resources in doing that, and it allows you to focus on building your knowledge and understanding to reach to the randomized controlled trials. We can't all start at RCTs, right? We have to continuously build on the knowledge that we are learning. You need to network, talk to peers, consultants, and faculty advisors. They can provide advice or point you to ongoing projects. And remember, we are lifelong learners. As physicians, learning never ends. Research skills should promote adaptability and awareness of your own abilities, equipping you to be a lifelong learner in changing medical landscape. Thank you.
Thank you, Dr. Bob, for that informative and detailed presentation. Now, we have heard how to prepare for research, how to write a research paper, and how we may be able to do research as students. However, I see many medical students present here, and you may be curious to know how to balance research with academics. That brings us to our next speaker. Dr. Keishan B. Ramirez is a medical intern at San Fernando General Hospital and a 2024 graduate of the University of the West Indies, where he earned his MBBS with distinction as well as B. Med-Sci with distinction. He was awarded for the most outstanding performance in both medicine and surgery clerkships during his medical training. Dr. Ramirez has a strong career interest in neurosurgery and is currently advancing his academic development through surgical research and postgraduate preparation.
He has contributed to several publications, including co-authoring a chapter in 60 Years of Independence and authoring surgical articles in peer-reviewed journals. His professional aspiration is to further specialize in neurosurgery, combining clinical practice with academic and research contributions to the field. Let's hear a round of applause as we welcome Dr. Keishan B. Ramirez to tell us a student's perspective.
Good morning, everybody. So I'm Dr. Ramirez, and pretty much when Dr. Marad reached out to me to have a discussion with you guys about the student's perspective, it kind of encapsulated three main points, which is curiosity, challenge, and growth, which is somewhat summarizes the med school transition into research. And first off, I just want to say this opportunity that you guys have. I really think that this was something that was made known to us when I was in medical school, to actually have part of the research curriculum be part of courses in your program of studies to get your MBBS. This was, for us, it was just, we needed to just do a research project, present that research in year 3, and that was it. We didn't really have much of, to say, learn a lot of the theory that you guys would have to do now, and I honestly think that is a significant advantage that you guys have, and it's not something to be taken lightly. Because I guess, like, you know, for medical students, it's if you're not coming for exams, we're already studying it, right? So with regards to data studies with chi-square analysis and those things, you guys getting a lot of experience with it now from early, so you can build on it as times go by. So the objectives pretty much is essentially going to be setting the stage initially, give you a bit of personal journey with my very junior research career. Challenges that we face, what students might gain, the roadmap to research, which I think is probably one of the most important slides on this presentation, as well as why is research important, which I think that part shouldn't really be there per se, because we tend to all understand the reason as to why it is we need to do research. It's pretty much self-explanatory, as mentioned by the speakers before, but we still need to include it. So starting with the baseline, everybody pretty much tends to start from a particular point. One of the early lessons I would have learned, especially from Dr. Marad, would have been, nobody could really tell you that you can't do this or you can't do that, or starting research is just probably wait for one as an intern or one as a house officer, or maybe a resident or something to start research. The earlier you start, really and truly, the better it is, because the more experience you would have from way before. And we could see the different levels of research, cohort studies, randomized control trials, all these things. It tends to go a very, very long way when you start early on. They start with something small like case reports, which is exactly what I did. And then you can build from there, because the learning curve is very, very steep, especially when you now start, right? So with my personal journey, I would have started research in year 2, when it is that we would have had our normal research day as medical students. I would have done my first research publication, which have been on diabetic retinopathy and the awareness of diabetic retinopathy at that time. The incidence pretty much worked out to be somewhere around 56% of people was actually aware of diabetic retinopathy then. And then we were able to do that research and get it out into the national grand rounds in 2021. The next paper, which I would have done, would have been with Dr. Marad. And this is kind of important to see, right? A good advantage that I probably would have had would have been through COVID. We were home. I had a lot of time on my hands to study, where it is I was able to not just pursue the academics, go to your lectures and those things, but also have the spare time to inculcate or introduce some sort of research and additional studies at that point in time. You guys being in schools, I understand it's definitely a bit more of a challenge, because you have PDQ, you have clerkships, you have spotter, especially for the pre-10 and paratennical students. But that doesn't mean that you don't find some time during the day in order to actually get it done. After that, would have done 2 papers with Dr. Maraj, and then the most recent thing, which would have been the chapter publication with Prof. Deluxe. A lot of learning moments pretty much happened along the entire platform, along the entire stage. First one, of course, which was data analysis. In Form 6, I would have done pure maths and applied maths, and the applied maths was very statistics heavy. So I had a lot of experience with dealing with statistics, numbers, chi-square analysis, and over testing, all these things. That would have helped me quite a bit, right? For those of you who don't have the experience with the applied maths or the statistics, the curriculum now introduces it, so everybody pretty much is at the same level playing field in terms of actually getting the knowledge. Now, this doesn't mean that at this point, because, okay, I probably know how to do a chi-square test to make my life easy, right? Not necessarily. Because when you understand and you get deeper and deeper into the research, you're like, oh, okay, there are things like forest plots. And then Dr. Marad would have mentioned a few other statistical testing. That goes a very, very long way into helping you write, helping you interpret data. And as Prof. Narrating would have mentioned, when you look at papers now, you tend to look at it with a different eye. For example, me, I like a lot of statistics, so if I go down to the results section, I would look at the graphs, look at the tables. I probably really wouldn't bother too much with what they write on the underneath or to describe it, because you have that experience. And that comes with time too, right? So that's eventually where it is you would reach, and then you would have to, basically other things to help compound and help your understanding there as well. Writing skills was one thing I personally was not initially good at. I wasn't really good at writing. But what I found helped was a lot of reading. When you read a lot of information and you continuously need to keep reading, you realize, oh, this is how certain people express ideas, this is how people write. And you tend to adopt some of those techniques indirectly into your practice. The research capabilities and the research skills, learning how to identify articles, these are things that you guys are now going to have to learn how to do the groundwork. Understanding how to write papers from the ground up helps a very, very long way. Because once you understand the fundamentals and the groundwork, you can then choose to build on the other things that is yet to come, right? This aspect with rejection. Currently, rejection is twofold, right? One with journals and one with personal rejection. Right now, we're trying to publish an article for the longest while. This is like about 2 years now, this is in the making. And rejection after rejection, right? And one of the first lessons I think I would have learned when it comes to research would have been when Dr. Maraj told me, say, Kishan, you're going to start research, right? You need to be okay with rejection. Yeah. And hearing that for the first time is like, okay, you hear it, but then you really listen to it, right? So immediately after we published 2 papers, I said, with rejection, nothing, my 2 papers were easy. The last paper now that we're trying to get out here is rejection after rejection. It's easy at that point in time to just be like, okay, I just want to lose interest, become very demotivated. But it's at that time you really had to pick yourself up and say, oh, okay, well, if it is that they didn't accept my paper, I believe in my paper, Dr. Maraj believes in it. We want to get it out. But because the editors don't really, me and the editors don't really see eye to eye on that particular subject matter, doesn't mean that it's the publication movie. So it's just about that persistence and that consistency. And I feel like armed with that knowledge, if it is that I probably did not receive that information before, it would have been easy for me to just, just trade it over. Be like, okay, research is probably enough for me, 2 papers, I'll just relax and rock back. It's not the case. Right? You'll pick yourself up and you keep going again. That persistence. On a personal level of rejection, recently I was on the word route. In a particular case, I was very, very interested. And our consultant at that time would have said, okay, we want the team to come together and actually write this paper and publish it. So I was very excited because it's a neuro case, so I was like, okay, cool. We could actually get it out there. Followed up afterwards with the house officer, after I would have, get permission, patient files, started to do a little bit of case presentation and everything like that, do my lit review for myself. reach out to the house officers now, be like, okay, so doc, I'm very interested in going ahead with this paper. If you have any assistance that I can offer, just let me know. I was immediately met with, no, this is my paper. Nobody else gonna get this paper, nobody else gonna get this research. I had to publish this because I had to write an exam. It's the first time somebody actually tell me something like this. So I think to myself, kind of took me a little bit off guard, right? Because you feel like, okay, well, you're motivated, passionate about the subject, but other people just, they kind of want to hold the research and kind of keep it to themselves, right? At that point, it's like, okay, no problem, my response, no problem. But I could easily have allowed that to just, again, be another point where there's a very demotivated experience. I'm reaching out to individuals, nobody's going to want me to do research. And I just leave that as it. Persistence, if you ask 100 people, and at least one person says yes there in terms of actually helping out with your project, that's all you need to know. You just need one to start. Right? You just need one to start. And I now understand that there are certain individuals out there who, even though there are research opportunities, and you could be how motivated and how driven, they're still going to tell you no. So, with that being my lesson to you, is don't really be demotivated and get derailed easily with something like that. Even though you're very, very passionate about the topic, right? I'm very, very passionate. It's a very, very rare pathology as well. And you would expect, individuals to be very, I just try to allow and bring in as much people as possible into the research. Especially because you're a consultant telling them, but because the house officers telling them, they know that's their paper and they want to write it. I mean, it kind of just took you a little bit on the off guard side of things, right? So what the outcome actually was, I still went home, I still did my, I was still writing the paper, but the knowledge that I would have gained from investigating the pathology, that still remained with me, and I'm going to lose that. Because I had a bad interaction with somebody, and it was from research, I don't really allow that to just spiral down and trickle down into other facets, right? So, challenges, medical students, time constraints. As should have been mentioned before. We have 24 hours in a day. I would say 8 hours you have school, 8 hours you sleep, medical students sleep 8 hours, right? That's 16 hours, you have left for 8. You take 2 hours to study, hour to eat breakfast, hour to eat dinner, that's 4 hours, you have 4 hours left. I think we can at least find some time during the day, but during that 4 hours, where we can at least put half an hour, 45 minutes, if you're real good, maybe an hour, right? Of research, once or maybe twice a week, behind the paper. What helped me was time management. And building that time management skill from early helped a very, very long way into being an intern, and I guess now going to be a house officer. Because as of midnight last night, I am unemployed. Internship done for me last night. So, now I have plenty of time on my hand, maybe to just catch up on a few papers, right? But year 2, year 1, it's I don't want to say it's bad, right? It's scheduled hard and bad, right? But each clinical, you have something, a lot of pressure, you have clerkship exams and stuff. Year 3, you have PDQ. There's always going to be some excuse in the book for you actually not to dedicate 15-20 minutes a day to probably writing something or doing a little data analysis or learning about something. I think we just waste a lot more time than that. We spend half an hour on TikTok and Instagram. I think I studied recently showed that you had about young people more than 2-3 hours spending on social media per day. Right? So we waste so much time on random things, but things that can actually benefit you in the long run, we tend to put it on a pause, put it on a cycle. The next one is mentorship. Because you guys here 1 year, 2 year, 3, having a mentor is important because there are a lot of things that you do not know, and you're going to need a lot of guidance on this particular subject matter. When it comes to mentorship, one of my consultants is happening, I know what I've said, I just want to make sure I get this correct, right? The eye does not know, the brain does not know what the eye does not see, something like that, right? Essentially meaning that if I could know that this is a water bottle, But if my brain doesn't know that there's a water bottle, I go and let's start clean. I don't know. These are the roadblocks and the stumbling blocks that tend to happen when you actually dive into research without doing anything. Diving into the deep end, ethical approval is one thing. You don't know too much about the statistics. The data collection process is a little bit of a challenge. Your writing skills like do all that. It tends to help if you have a team and you have a mentor who to go to with these challenges to help navigate the roadblocks a little bit easier when it is actually conducting the research. We spoke about rejection before. Be comfortable with it because it's something that is going to happen to everybody in research, and the underlying principle is not to get you really demotivated from that. Resources. When it comes to resources, the literature search is broad and very, I just want to fast forward 2 things there. You have balance and enthusiasm with limited experience. Young and vibrant medical students feel like after today we could probably go on to a randomized controlled trial in the evening, right? But then all the issues and the pitfalls with funding and not knowing where to go tends to pop up, and it tends to pop up very quickly. Okay? If you go ahead and you can go ahead and try it, it's no problem. But again, academic fraud, all these other things, and you don't want to be a victim of academic fraud, especially, I mean to anybody, right? But especially in an early medical career. Because your medical career pretty much over at that point in terms of trying to publish. So it has to be a little bit more careful. Working as part of a team is a challenge, but it's also a very, very good thing. Team dynamics, sometimes you work with difficult people, sometimes you work with really amazing people. I was fortunate enough with my papers, I work with very amazing people to help get it out. The team is a very useful thing if utilized well. One of the papers we're working on right now is the study of PRP injections and the knee in the treatment of osteoarthritis. We have individuals who actually very good with data, very good at writing, very good with research. Having a coalition like that is very, very powerful when it comes to publishing a paper that is research worthy and that is going to have a very, very significant impact on the studies moving forward. Okay? So, what students tend to gain from research? This is just pretty much a word cloud. I left it very sparse for a particular reason. Because it's up to you really and truly to just fill it in, and you will realize slowly but surely these are some of the advantages that you are gaining when it is you actually do research. And it's not just limited to this. There's a whole lot more that actually lies underneath the benefits towards research. This is the most important side, I think, for me, the practical roadmap. Okay, this is what somewhat helped me. The first part is finding a mentor, and it kind of goes into the second part, right? Pick a topic or follow along with your research. The clinical students may have it a little bit easier here, in the sense of you're around individuals and residents, surgical residents, medicine residents, who are actively doing research, and they're consultants as well. So you already have people at your disposal who are doing research. The pitfall here is when, if it is that you show up to water rooms and you introduce yourself and you are like, okay, so I am Dr. Ambrose, I just want to, well, you're a full medical student, right? I'm very, very interested in doing research, and I would like to be able to assist with a research project that you're working on. You introduce yourself like that, it's fine, take it. But like Dr. Manuel mentioned, I mean, they're not going to meet you, nobody know you. You might bring some things to the table with, okay, I could do data analysis real good, I can write real good. But then afterwards, they never see you in the theater. You want to leave early to go home. You want to stay until 10 o'clock in the night because you find that it's too late. And you want to just go home and I had an exam to study for. And believe it or not, your consultant paying attention to these things, and your residents and your house officers and registers paying attention to these things. And you really think at that point in time they're going to be, I feel like I'll take them stuff to help write the paper. You're not showing the initiative that you actually want to be a part of the research team. So It's nice when it is okay, I'm have a light day, but then switch rough rotation now. We had to stay here till 10 o'clock. I come early for rounds in the morning. Consultant reaching half 5, 6 o'clock to start rounds. But you want to leave early, and you don't really leave that impression that, okay, this is something that I want. I just want to be part of the paper. It's not about just putting your name on a piece of paper. You have to show everybody that this is why you think your name deserves to be on the paper. Alright? Start small. I started with case reports. Case reports are a very good way to get into the research community. However, there are other aspects of research or things to put on your CV that are very practical. Dr. Bobo mentioned audits. Audit, a closed loop audit makes the most sense. Because it's not just about, okay, I want to see if it is that we follow a particular guideline and these patients receive this particular type of treatment. The real benefit is when you introduce your intervention into the population, into that particular group, and you do the re-audit to see if there's had any change. It's also a very, very good thing, a little bit less time sensitive than actually doing a big research project that you could actually put your name towards. Another thing that you could do is presentations. It might be hard sometimes to find time to do a full research paper, to have the time to sit down and actually write the paper. But any kind of presentation, this could very well be national grand rounds, it could be, if you want to do regional grand rounds, international grand rounds, no problem. But there's also grand rounds in the hospital that you could do. And as I intern, I remember doing a neurosurgery grand rounds on subarachnoid hemorrhage. I found it was a real interesting presentation to do. Real cool case that we actually had in theatre. Right? And you could start with those other aspects as well. It doesn't necessarily, and the thing is, I try to be as transparent as possible to let you know that there are there are multiple avenues to enhancing your portfolio. It doesn't just need to be research oriented entirely, or publication oriented, I should say. You have case reports, you have audits, you have presentations, you have posters, grand rounds, your student research presentation. That's also another thing that you could have. You could also put on the CV as well. And then you can move up into case reports and randomized control graphs, etc. The skills that we tend to build as we write a research paper, but I've mentioned them before. But ethical approval, I think, I don't know the year one's probably do it now, but I think for the year 2 you would definitely need it for your research team, right? Having that in itself is a ticket for you being able to start your research. What I would advise is maybe the year 1, year 2s, even the year 3s. Your lecturers, if it is you're interested in a particular topic, whether you're a biochem lecturer, anatomy professor, physiology professor, they would likely be doing some sort of research as well. And if you're very interested in that particular topic, send them an email or after class you meet up with them or something. Show initiative, right? Introduce yourself, make yourself known. And then you can actually get it out there. And I think that was probably the hardest step for me to maybe take the direction as to where to maybe start with research. Everybody say, okay, I need to do research, but how to actually do it. This is the way forward for you to actually start this particular process. Very long process, but it's a nice way to start. It's by reaching out to people. Okay? You'll interview your data analysis and your references. The nice thing about it also, working with a team, is you get to learn from your other team members as well. If one person is good in data analysis and the other one is good in writing, everybody could be, oh, okay, well, we could just speak with our citizens and you have. But then, when you read that paper, you really realize it. If 5 people was that paper, you can tell 5 different people right there. But working together, everybody needs to have some level of skill in every department to help that paper make sense. And that's where, on the leadership, I mentor and a supervisor, and PIs, this is how it's done, like that, right? Consistency, very, very important. Not just because you push real hard on one paper, you feel like that is it. The more and more curious you are, so like the curiosity aspect of it comes in, the more involved you are in a particular topic, it tends to be a little bit easier. Because once you really understand, okay, this is how research is published, you understand how to navigate some of these roadblocks and these challenges a little bit better. they tend not to make the same mistake twice, right? Maybe sometimes you do, but not as grave or grievous as the last one. Mistakes are part of the process. We make plenty of mistakes already, especially when it comes to research, right? ChatGPT is a free AI tool, but caution against using it when it comes to your statistics and your data. Personally, I tested this theory myself. I did my own statistics with IPSS. There's some random numbers, right? And I did my own, and then I put it into chat. And the value that chat gave me, I want to know if I really am truly doing something wrong here. The other data points that I put in, I get the same answer, so I feel nice, right? I say, okay, well, maybe I could verify it to that perhaps. But then when they give me this kind of crazy answer afterwards, my p-value, the p-value I got would have been less than 0.05, right? And p-value they gave me was 1 point something. And I realized with them, I need to double check everything that I put into chat, especially my data and my calculations, before I put it in there. Even if you use chat as a tool to enhance your writing, which I personally don't really like because I feel like, you can use it maybe to show how this information could be better phrased. The syntax and lexicon and stuff would be nicer. But I think a good piece of writing comes from when you actually sit down and you put it together and you actually feel nice about that. And that comes with reading. Reading and that's basically the same thing I would have said before. Reading articles published by other authors before tends to train your mind indirectly into writing in a particular way. And that skill tends to develop and it tends to grow. And these things will just leave you, but if you don't use it, you'll lose it, right? If you don't use your statistics and stuff too much, you tend to forget it and you might just have to do some refreshers and things, but I mean, that is neither here nor there. The bottom line is, you knew it at some point, so it shouldn't be too difficult to actually get it up back to back. Celebrating the milestones is important. You would have completed a particular section on your project. Giving positive feedback to your team members and your colleagues and peers tends to help. It goes a long way. If you congratulate them, okay, so good work on doing this lit review, let me see how best we can move forward. When you have motivated individuals and your team is so much easier to get stuff done in a very, very quick time frame. Very, very quick. But if it is that you have poor communicators on the team and individuals are very, rude or aggressive, conflict tends to disseminate a little bit, and it's that much more difficult to navigate these personalities. Okay? Last slide here is the why, and a slide I really think that shouldn't really need to be put up, but looking back on it, I kind of decided to still put it up, to let you know honestly what was my reason for going into research. My reason for going into research would have been number 2, just build an IC. That was the initial thing. Then I get to realize this isn't all the reasons, right? I have so much more. But then I get to realize, wait now, maybe a prerequisite for postgraduate studies as one. Okay, so it becomes a bit easier to, if I want to apply for a particular program, not just locally, but USMLEs, MRCP, MRCS, for those of you who want to leave and figure out that, okay, well, I just have my MBS, everybody had MBS. I will have my MRCP, everybody probably had MRCP too. Right? So it's the same CV or the same portfolio that every single person you have applying with. And likely a few of them now have real research papers behind the name too. So how are you really going to stand out on if it is a start behind the paper? If you have no research at residency level or approaching residency, and then you now decide that I want to apply, you get to realize how much of a challenge this is now. You have to now catch up on a lot of things. So starting early is important. Very, very important. Then you get to realize that now I could actually contribute to better patient outcomes. Case reports, where we start. You work your way up to initiate policy changes with randomized control trials. And then new skills to learn and apply. I can't tell you how important it is. Even when reading now, it could just be a book. You tend to critically analyze the book on a different, basically different understanding. Or you look at it through a different light. And that comes with time, it comes with practice, and honestly, when I say this, and nobody judge my faith, it's not hard. Okay? It's really not that hard. It might seem hard when you have PDQ to prepare for and you have spotter coming up next week. But I remember when I had a particular situation come up, I think I had injured my hand, and I had messaged Dr. Marshall with Dr. I have an injury in my hand. I wouldn't be able to, help type up the report and say, but don't worry, I'll get it done as soon as possible. Dr. Marshall thought it was okay, hope you feel better, and it's not a problem. Clear communication, clear relationships, being honest and open about things. You have, right? Okay? Honest problems. And you be transparent. It's easier to communicate. To get the paper out is not a problem. But it's the follow through with these things. And sometimes we tend to get a little bit lost, and we understand that things come up. Everybody in medical school, and everybody understands that life tends to happen. And sometimes if something comes up, let's mention it to the supervisor, mention it to the API, it's an email or a text away, it's so simple. And then afterwards, once everything is sorted out, you can always fall back in. It's not a problem. But the consistency and the motivation starts with you. Then it comes back to the first slide. It's not difficult to get it started. It's not. But however, you decide to move with your research and move with your research career, it's entirely up to you. Nobody is going to tell you this is what you need to do, this is how you write the paper. Nobody's going to be behind you like that. This is tertiary level. Nobody's spoon feeding you at this point anymore. And you need to have that own level of understanding and self-directed learning to push yourself forward. Not everything they teach you is what you need to know. There's so much more that is outside of the curriculum that is required. And as you do it with the experience, that tends to come with time. Alright? So I think that brings my little talk to an end. Alright? So thank you all very much for listening. I don't have any questions and answers. I don't know if you don't have to, right? Okay? Alright, thanks everybody.
Okay, thank you so much, Dr. Ramirez, for that talk. So, we heard from a lot of respected doctors today. We heard how to write a research paper, how to prepare for it, research for medical students, and a student's perspective. I hope that you all learned a lot today, and if you need clarification on anything, now we'll be taking any questions from anyone in the audience. Nobody has any questions?
Just asking one question.
Yeah, sure.
I don't think I need a mic unless I need it. I do have a big mouth. Dr. Moran, Dr. Ryan, Dr. Bob, and Dr. Ramirez, thank you so much for your input and educating us today. I just have one question. Let's say, for example, I'm a student or a junior doctor interested in research, and I want to come to you as a mentor or PI to try to get this research topic started. Do you believe there is something that I need to come with? Should I have a research proposal outline initially when I come and interact with you? Or, just have a research topic idea and then we work on it together?
That's Adam Ali, right?
Yeah.
Yeah, and then Adam turn around. Yeah, my mouth not as big as yours. I need it in my. So, you have to know your colleagues, right? You have to. I think Kishan, he said it well, you have to develop a reputation so that if you come to me and say, well, this is so and so, yes, I know you. You work hard. I know that's how you're diligent. See on the words and things you're looking at. So I think that is one of the things. When you communicate with us, I think I mentioned in my talk that somebody contacted me recently, introduced myself introduce yourself via email. Yeah, and which is fine. I don't mind that. I don't know, Prof, how it is you think about that if email is okay. If you don't know the